welcome me.
Yeah. But jab tak patient is getting ready for the surgery, please do the CT. The moment the patient is ready for surgery, please stop the CT. Both ways. Okay.
Okay.
Yeah. So in this course, we are going to introduce a concept of a rapid CT reading. Of course, these guys can read a CT for the whole day, one single CT. But what do we necessarily need to know in terms of the surgery that we are doing? The bare essentials is also something which we should cover.
So Ashish,
Yeah, Satish. Yeah.
first of all, I would like to mention
Yeah.
something about the Pune. Coming to Pune is like homecoming.
So use the word Pimpri because okay.
And working with this dream team, the Arvind, Amol, Vivek, is like something
Yeah.
I always dream to work with. And this is a special event where the Ashish is there, our dear friend Janki is there, Dr. Deepak Haldipur is there. So we are going to have a great time with these people. So, coming to the topic, and another thing about the course is so well structured that Arvind has designed the cases he has lined up the cases in such a way that we are going to start with the basic cases, then little advanced, and then in the end with the revisions. But we'll stick to the sinus surgery only, nothing beyond.
Yes. So today is predominantly primary and tomorrow is predominantly revision surgery. That's how it is structured. Yeah.
So now, before the case is induced, I'll go through the CT as you asked me.
Yeah.
And I'll stick to the points which are relevant clinically.
Surgically relevant. Yeah.
Before going to the CT, what kind of a CT scan we need to know.
Yeah.
Ideally, why CT is important? CT is like as we always say, as a road map. To me, it is a Google map for anatomy of the sinuses. We all know the sinus anatomy is so complex, and we have to work in this field close to the orbit, skull base, and all these structures. And the importance of the CT lies in giving you a three-dimensional information about the anatomy of this entire paranasal sinus labyrinth and the relationship with the surrounding structure. And the anatomical variations are so common. So every patient you need to know the details of the anatomy. The kind of CT scan which I order, if the patient comes to me primarily and if I order a CT scan, we order a less than 1 millimeter thick slice multiplanar axial coronal sagittal scan in both bone and soft tissue window. Like we have our own CT scan in our hospital, we get 0.625 mm slices. So you don't miss anything. Any structure less than 0.625 millimeter in thickness, as we can miss. So here lies the important structure. Like if you say the anterior artery, the thickness is around 0.9 millimeter. You can't miss with that. So in less than a millimeter, you generally don't miss. If you are so unlucky that the slice has not fallen off that point, that only you can miss, otherwise you can.
Satish, get your mic a little bit closer so the impact is better.
You got what I am trying to say?
Okay,
Hello?
Satish, sorry. There's a suggestion.
Yeah.
Between the bone windows and the soft windows, what exactly is the difference? What is it that you can tell? Can you elaborate?
Yeah. CT gives us the bony details, or the best investigation to give bony details. We all know soft tissue details are never given better by the CT scan. But yet, the differentiation of the soft tissues to some extent can be noted on a soft tissue window CT scan. That's the only thing. For the better soft tissue detail, of course, you need MRI. But in this benign sinus inflammatory disease, you don't need MRI unless the disease is going beyond the confines of the paranasal sinuses, or you are suspecting some tumor, or sometime you want to differentiate whether there is fungus or not. You can order MRI. Otherwise, it's not needed.
Okay.
So, like this scan, if we come to, we have a coronal scan, and we need to know the coronal scan in detail. The reason being, the coronal, see, there is always a debate what kind of scan you need. You need whether sagittal or axial along with. To me, yes. But practically, most of the time, the coronal gives you most of the details which you need, and that too in the same plane in which the surgeon operates. So you have a easy understanding of the coronal scan in the same plane in which you operate. So like in coronal, what we are going to see, like if you see this picture, can you focus on this? Kind of scan we are going to take, or the scans are taken from anterior to posterior in this plane. Okay? And this is what I have read on the CT is 2.5 millimeter thickness. So every time we move on behind, we are going to have a
distance of 2.5.
jump of 2.5
Yeah.
millimeter.
Yeah.
So that is important. So if I go quickly, I think I have 10 minutes because the patient is still being induced. So the first scan, like you see in the coronal, the most anterior, there are certain anatomical structures. We need to know anatomy so that we can appreciate the pathology as well, because anatomy can be different in different situations. So in first scan, what we see here is the frontal bone with two pneumatized spaces, and below is the two nasal bones you can see with the frontonasal processes. This is the upper part of the bony nasal septum, that is the upper part, the perpendicular plate of the ethmoid, and the lower cartilaginous portion in the ala. We don't see anything much. We are going to stick to the clinically relevant things. So if I move on to the next one, we see some partial opacification in both the frontal sinuses. These are frontal sinuses because the floor of the sinus is intact here, and this is intersinus septum with partial opacification. And see what is there below, which is coming up. To me, it looks like intersinus septal cell in the most anterior section. See, just behind the nasal bone. Earlier was the nasal bone proper picture. Now we are moving behind. This is the looking like the most anterior appearance of the intersinus septal cell. And what you see in the nasal cavity on the right side is opacification, looking like some polyp or something occupying the right nasal space. The left one is little clear, and there is some deviation looking like the septal deviation. This is important clinically. See, in CT, we are not supposed to see the anatomy of the sinuses only. We need to see the other structures as well, like turbinate, septum. Many a time we need to deal with. In my personal opinion, over 90% of the situation you need to do something with the turbinates and the septum. So,
Okay, Satish, sorry to interrupt you. That interfrontal cell that you're talking about,
yeah,
is it clinically or surgically relevant
yes,
to this
very
case?
important, very
To
important.
this case?
Yes.
Yes? Okay,
See, this
fine.
is pneumatization which occupies the frontal recess ultimately. The outflow of this is one of the frontal recess, and it is draining into one of the frontal sinus. So sometime when it is big, it
Okay,
can push
so
the
it will
frontal
block.
outflow little lateral.
Okay, fine.
And it can make your situation difficult. So you need to know if
Okay.
there is frontal sinus
Yes,
cell.
yes, yeah.
Now I was talking about the septum and turbinate, why they are relevant. In our country, we can post the case for sinus surgery, and if required, we can do septum, turbinate. We don't need to take any separate consent. But in the Western countries, if we are doing septoplasty, turbinoplasty, we need to take separate consent, and we need to know the situation of the septum and turbinate. So if there is like a gross deviation, you may have to do something, and you can tell your patient beforehand. Now, moving further behind, see what you see, the swelling of the septum at this level. This is septal body. That's the natural appearance of the septum over here. Now you look at the interfrontal sinus cell, what I am assuming. Hello?
Yes, yes, we are with you.
See
Yeah.
the well developed frontonasal processes.
Yeah.
These are two frontal sinuses, which I said the partial opacification. This is again to me the intersinus septal cell coming up, and this is the opacification on this side. Now coming behind, see the next picture. Until now the floor of the frontal sinus is absolutely intact. We all know the frontal sinus drains from behind through the frontal recess, from the posterior most part. So if you are going from anterior to posterior and see the frontal sinus floor intact, which is formed by with this thick bone, which we call as the beak. So this beak forms the floor of the frontal sinus, and when the beak goes away, that means the frontal recess you are entering. So now, moving to the next picture, see the change in the appearance, the sudden change in a lot of structures, appearance. Can you now see a better picture of the intersinus septal cell?
Yes, yes, very well.
So
It's much
it
big.
appears like this. If it is too pneumatized, anteriorly it will be seen just behind the nasal bone. And the only structure which comes behind the nasal bone in such a situation in the midline cannot be anything else than intersinus septal. Now you see a better picture. Now, intersinus septal cell opens in one of the frontal sinus. That you can make out from CT scan very clearly. So once you are dealing with the frontal sinus, you need to know that medially there is an intersinus septal cell which you need to join. If there is some inflammatory disease or some blockage is there, you need to join that. Now, coming behind, look at this picture. Until now, see that we have entered the frontal recess, the posterior part of the frontal recess we are now going to. Until now, see, go to the previous slice, boss, mere saath saath chalo. If you go to the previous slice, we don't see any evidence of maxillary sinus coming into the picture. Can you see?
Yes,
Now,
very well. Yeah.
we are leaving the frontal sinus. You see the frontal floor is
Okay,
breaking.
so Satish, I am going to do now. The rapid thing is up to these now 4 cuts.
Yeah.
What is the conclusion? That yes, there is a
Conclusion is-
normal pneumatized frontal both sides.
Both sides.
There is no hypoplastic or an absent frontal.
Absolutely.
2 is there is an interfrontal cell,
Yes.
and there is a septum which perhaps is deviated.
Yes.
Is that right?
Yeah. And the
Is that-
fourth is there is opacification of the frontal sinus that
Ah,
requires
no, yeah,
exploration.
no, yeah, sure, no, okay, yeah.
Now, coming to this picture now we see the beginning of the appearance of the maxillary sinus.
Yeah.
Can you see now?
Yes,
Generally, when you see the frontal sinus first, you don't see the maxillary because maxillary are at a posterior plane.
yeah.
Now that's the beginning of the maxillary sinus, and by and large you can make a sort of thing like when the maxillary sinus come into the picture, the frontal goes off. Unless it is too pneumatized or whatever, that is unusual. And see now, that is the picture of the frontal recess. Now you don't see any thick floor underneath the frontal sinus.
Satish, correct me if I'm wrong. Are we supposed to see the agar cell before we see the maxillary?
Yes, we are seeing
Yeah,
that.
we are
going
seeing
to see.
it. Okay.
Maxillary means this is the anterior most.
Okay,
Anterior wall
just
of the maxillary. See, on that the side. The
no,
picture
almost
is
not
tilted.
seen. Yeah, just the bone.
appearing.
Okay,
So agar is going to be now coming. Now in this section, if you see, there is no frontal sinus. You need to know what is frontal recess. Now, when the frontal sinus ends, the floor goes. This is the beginning of the frontal recess. This is just the beginning. And see whatever pneumatization going laterally at this level.
yeah.
When the floor has gone, the maxillary has appeared, and the pneumatization extending laterally, looking like frontal. It cannot be frontal.
It's the recess now. Yeah.
This pneumatization is variable sometimes, very extensive, going beyond the. See, in the next picture, this pneumatization is extending up to here. This rest of the bone is not pneumatized. Can you see?
Yes, beautiful.
Sometimes it can extend beyond. Sometimes we have seen this is the floor of the intracranial fossa, the roof of the orbit. Sometimes it goes laterally, even pneumatizing the zygomatic bone. We have seen pneumatization of the zygomatic with opacification. But in this case, this pneumatization is extending up to here. Can you see?
Yeah.
So that's how you need to make up how your supraorbital cell or the recess is placed. This pneumatization, over pneumatization of the supraorbital recess has a lot of clinical implications. See, more the anterior skull base is pneumatized, more the walls or the bony walls going to be thinner.
Yeah, sure.
Less pneumatized, thicker
Again,
wall.
sorry to ask a question. Is the supraorbital associated with the anteroethmoidal artery, or are we already
Yes, it has a relationship, not associated.
Okay.
You can infer the location of the anteroethmoidal artery. The reason being, the more supraorbital pneumatized, you'll find a good cell, big cell, and then you can assume the anteroethmoidal artery is going to be immediately caudal to it. So it helps you in locating the anteroethmoidal artery.
Okay.
There is two pneumatized.
Okay. Sorry. Come back on the track. Yeah.
So that's a good question, I would say.
So welcome, our president, Dr. Deepak, very dear friend. He's here.
Boss.
Satish, if the supraorbital cell is well pneumatized,
Yes.
Is it that the anteroethmoid artery will be hanging from the
Yeah,
mesentery?
Could be. See, I mentioned that if there is too much of pneumatization at the anteroethmoidal skull base,
Yeah.
the bone is going to be thin. And
Yeah.
how the anteroethmoidal artery courses through the thickness of the anterior skull base.
Yeah.
So if the thickness of the skull base is thin, the artery is going to be prominent.
Yes.
If it is too thin, it may be in the mesentery uncovered by any bone.
Okay.
So if there is not too much of pneumatization, sometimes you may not find the artery running through the thickness of the skull base.
Yeah.
So it depends upon the pneumatization in that particular situation.
Okay. Thank
Now,
you, Satish.
coming to this picture, Ashish,
Yeah.
this is a very good picture, and what you see on both sides is the nasolacrimal system. Can you see?
Yeah.
Nasolacrimal system. Now,
756
there is
log.
some cells, though there is opacification, we can't make out very clearly, but this is the point. See, what is agarnegi, like you mentioned, that is pneumatization of the lacrimal bone. The ethmoidal cells pneumatizing the lacrimal bone, and in relation to the nasolacrimal system, the first cell appearing in this region, anterior-most cell, like I put an endoscope, you'll see above the axilla, that mold even anterior to the axilla is the prominence of these agarnegi cells. And here you see, I can appreciate some pneumatization. This looks like a cell, and this is most likely the Aganese cell in this region. These are the most anterior cells on CT scan when you come from anterior to posterior.
If you say so.
Yeah.
Is the anesthetist listening to your lecture or putting the tube?
No, he is there.
He's there. Oh, okay, go ahead. Sorry. Yeah. Okay. Sorry, Satish. Carry on.
No, it's all right. So, in the frontal recess, we need to know what kind of cellularity is, and this is best depicted by the sagittal reconstruction images. Here you can't make out that kind of a three-dimensional scenario on the coronal only. But yes, Aganese are the most important cell, and these are one of the determinants of frontal sinus outflow. How the frontal sinus is going to drain into the middle meatus. So, this is the anteriormost picture. Now going behind in the frontal recess. We are still in the frontal recess. Can you
Satish,
see?
sorry to interrupt.
Yeah.
Are the skull base levels different on two sides in this case?
No, the picture is looking tilted.
Okay.
You see the difference on two sides. The picture was taken, the shot when the patient was little tilted.
Okay.
So, and sometimes your question is right, sometimes you may find asymmetrical
Yeah.
skull base or the roof of the ethmoid. Now, at this level now, we are going further behind, jumping by another 2.5 millimeter. What you see this configuration is the anterior ethmoidal skull base. We all know this is formed by the cribriform plate, and this how configuration is. This is the horizontal lamella of the cribriform. This is the lateral lamella, and that continues as the roof of the anterior ethmoid cavity. That is the part of the frontal bone, the thick one. The thin lateral lamella is a part of cribriform. Can you make out? Is that picture clear?
Yeah.
And this is the crista galli in the middle. So this is now the proper picture of the cribriform. What we need to see, clinically relevant thing, how deep is the olfactory fossa. See, this is the level of the ethmoidal cavity in terms of height, and this is the level of the floor of the olfactory fossa. So this height of the olfactory fossa is an important clinical relevance. Reason being, you are working in the frontal recess in this patient like this. Now this height is very important. If it is too long, suppose this lateral lamella is too long, you have to be in relation to lateral lamella with your instrumentation. So you have to be very, very careful. If it is too long, you are in relationship for a longer distance where you are working. So chances of injury are more if you are not careful, if your instrument all of a sudden hits or whatever. So in this patient, this Kiros, that's what Kiros is defined. It's a very clinical classification. Type 1 Kiros means a simpler situation, less likely to give complication at this point of view. Type 3 means the long lateral lamella, you have to be in relation with the long lamella, and you have to be more careful. So that's a clinical classification, and one needs to see in every case what kind of Kiros is there, if there is any asymmetry or something. And what you see at this level, Ashish?
Yeah, Satish.
See what is the structure coming down from here. See right exactly at the junction of the horizontal and lateral lamella.
Yeah.
This important structure coming down is the first part of the middle turbinate,
Yeah.
lying in the sagittal plane, exactly sagittal plane.
Yeah.
Okay. So that is important to find out how the turbinate is placed. At this level, in this scan I can't appreciate, otherwise you can appreciate the uncinate, how it is going. Mostly the uncinate goes fused with the medial wall of the Aganese and goes laterally insert on the lamina. That is again a determining factor for the final frontal recess outflow.
Yeah.
Because the important thing is, if it is not going laterally and going medially, you have to be careful in dealing with the uncinate, otherwise you can
So Satish, and I'm going to get Janki also in this. Can you, we'll just deviate a little bit.
Yes.
Can you tell me surgically, when you say you have to be careful or whatever, what different do you do when the uncinate is inserted to the skull base versus its natural course of lamina?
That's very important.
Is there an instrumentation that is different?
Yes.
Is there a surgical stroke that is different?
Yes,
What?
absolutely, absolutely. See, many a times you can remove the uncinate by the microdebrider, you can remove by going behind and fracture it with a curate, or by any other means. If the uncinate I know is inserted on the skull base or the upper part of the middle turbinate, I'll be little careful in removal, and I'll be using a sharp bite through the uncinate so it doesn't mobilize anything beyond. So that's the important thing.
So okay, can a debrider damage it?
Yes.
If you don't use the if you don't use the sharp cutting,
Ideally you should.
No,
The glider
ideally.
may or may not. See,
May.
what the important thing is, while dealing with the uncinate, if you transmit your instrumentation pressure, it can lead to a distant fracture at the level of the cribriform.
Okay, because
So-
I hear this all the time, and honestly,
Yeah.
when I'm doing the surgery,
Yeah.
I've never even once done something. So this I'm
It's
trying.
very
This
uncommon.
is
I think
I'm
this is
being
very
very
uncommon.
very uncommon.
And
Na?
secondly-
Because that bloody Stamberger drew those
Yeah.
3 diagrams, and I think we are all like
that is
rats
right.
following it.
And see, secondly,
Yeah.
what happens? The thickness of the uncinate varies.
Yeah.
If there is too extensive disease, that might be a thin plate. You can remove by any means.
Okay.
Don't even appreciate what you have done.
Yeah.
So that can go unnoticed. That can go unnoticed. But it depends. You need to be careful. Once you
Okay.
ask how it is to be done, it should be like that.
Okay.
Now, going behind, we are still in the frontal recess. Ashish,
Yes. Yes. We
we are
are
going further behind.
Yeah.
You can see again the same middle turbinate configuration.
very well.
Some cell looks, see on the both sides, the picture in the anterior ethmoid is different. We can see some of the cells in this region.
Yes, we can see.
Now
Yeah.
that
2
is the
cells.
time, yeah, the bulla should be there, but I don't appreciate because of the opacity. That is completely opacified in this region, and you see the maxillary sinus becoming bigger, globular in shape in this region. We can have see the full picture of the globe. This is the orbit, this is the globe, and if you go behind, there are certain things which I always see to look for to relate in the sinuses. Like in the globe, if you see, this is the globe, this
Yeah.
is the medial rectus muscle, can you see?
Yes, very well.
Inferior rectus, superior rectus, this is superior oblique.
Yes.
See, if you relate, if you've seen me dissecting many a times in cadaver, I always show how the anterior ethmoidal artery comes into the ethmoidal labyrinth.
Confluence of the superior oblique and
Yeah,
inferior.
this is where the anterior ethmoidal is a branch of ophthalmic. It leaves the orbit.
So we can't see. Camera has
Yeah.
to move. Yeah. Okay.
Yeah. It leaves the orbit between these two muscles, the superior oblique above and the medial rectus below. And see, if you keep your eye while walking, looking at the CT in the anterior ethmoidal roof, see in the next scan, can you see something?
Yeah. Yeah.
This is the medial rectus, this is the superior oblique. That's the confluence of these two coming close. If you see very carefully in the next scan, can you see?
Yeah.
Coming more close,
Yeah.
and now you see exactly what is there. Can you see this?
Yes,
coning
yes,
of-
yes, yes, we
coning
can
of the
see it very
medial
well.
wall, and that beaking signifies the artery leaving the orbit. That's a very, very important point you can pick up on the CT scan. There are many ways to see. I will correlate the same in the surgery, how this artery can be correlated in
Satish,
difficult situations. Yes.
News from the live streaming. 756 people already online.
Oh my God.
Yeah. Compliments coming from
That's
Calcutta
one-
and
that's
yeah.
one
Anyway,
Saturday.
carry on. Yeah, yeah, yeah. So tomorrow we are hoping 1500 or more. I think this will swell up. Yeah. Okay.
Who knows?
Yeah. So it's there on the handphone for yeah.
Now,
Okay,
Ashish,
sorry. Yeah.
the most important thing which I am going to show here, and
Yeah.
I'm going to correlate clinically as well during surgery, the level of the anterior ethmoidal artery.
Yeah.
You see here, in the posterior most part of the anterior ethmoid, we have seen.
Sorry,
these
sorry.
slices
Say it
in-
again. So say it again. Level
Here-
of the anterethmoidal artery and the
Yeah, we enter the anterior ethmoidal roof in the frontal recess.
yes.
Then we went through to 3 slices behind.
Yeah.
Now we are in the
So
posterior part of the anterior ethmoid cavity.
Okay.
Roof.
Okay.
This, the cribriform is still there.
Okay.
And now we see the anterior ethmoidal artery.
Yes.
So what does it mean?
7.5
Clinically?
millimeters. Yeah.
See now, this is still the middle,
Yes.
middle turbinate first
Yeah.
part,
Yeah.
and this is the anterior ethmoidal artery.
Yeah.
Now see in the next scan what is happening.
Mm.
Where the middle turbinate going? Laterally. Can you see now?
Yes. Yes.
And see the roof is changing now. It doesn't look like the cribriform now. And now see the next scan. That is the roof of the
Flat.
ethmoid.
Posterior. Yeah.
So what does it mean?
It means a
clinically?
narrow.
That I am going to show in the scan. The moment you see the anterior ethmoidal artery,
Mm.
the anterior ethmoidal roof ends.
Yes. So it's a
What's
very
my point?
short and skull base, 5
No,
millimeter.
this is from the identification of this artery point of view.
Okay.
The moment you see anterior ethmoidal artery,
Mm.
what you see in the next scan is the ground lamella.
Okay.
So clinically, when you see the ground lamella and you see where the ground lamina is attached up onto the skull base, the anterior ethmoidal artery is almost always immediately anterior to it. Got my point?
Yes.
What I am trying to say?
Yeah.
You can identify the artery in many ways, coming from the anterior like the frontal sinus ostium, then one cell like fovea or the supraorbital recess, and immediately behind is the artery. Many a times you don't find the artery that way. And the best way, believe me, because the anterethmoidal roof pneumatization is variable. But this relationship is always fixed.
Yeah.
The moment you find the middle turbinate ground lamella and you see the attachment up onto the skull base, the anterethmoid is immediately anterior to it. Got my point?
Yes, yes,
This
got
is
it.
in few millimeters relationship with the upper attachment of the basal lamella
Yeah.
onto the skull base.
Yeah.
And see, once the anterethmoidal artery is over in the CT scan, immediately after the posterior roof starts.
Yeah.
That again signifies the anterethmoidal artery is always in the posterior most part of the anterethmoidal roof.
Yeah.
Got my point?
Yes, yes,
Is
got
that
it.
clear?
Got it. Yeah.
Now, once the posterior starts,
Yeah.
now see there are certain changes. Unlike the anterethmoid, there is no cribiform now. The skull base, now you go behind the skull base, roof is thicker. The orbit is becoming smaller. It is coning behind. And see the changes in the maxillary sinus. This thing.
Oval, yeah.
Oval, it's becoming more oval and smaller. And see the cells larger. Now there are two turbinates. See now,
Yeah.
unlike the middle turbinate,
Yeah.
they are going to the roof
Superior.
of the posterior ethmoid. So these are superior turbinate. This is another, like you asked, the clinical relevance. The moment you enter the posterior ethmoid, they are bound medially by the superior turbinate.
Okay.
All the way, right from
Yeah.
anterior to posterior till sphenoid. That's
Yeah.
the medial boundary of the posterior ethmoid. So again, posterior ethmoid is like a box. I am going to show during surgery how it is related and what is the importance. Now, once you move in the posterior ethmoid behind, now what you need to look on CT scan as a person you know how to read, you need to know the transition from posterior ethmoid to sphenoid. Okay?
Yeah.
And the simple two things will take you where the sphenoid begins. See in the posterior ethmoidal roof. We are in the posterior ethmoidal roof. The two things you need to see. One is the nasal septum coming from the floor to the roof.
Yeah.
That is still posterior ethmoid. And see the roof of the posterior ethmoid right from
Flat,
terion
yeah.
to terion. This plate of bone. Can you see this?
Yes.
Now, as you go behind, still this is posterior ethmoid. Can you see now?
Yeah, very
the
well.
septum is intact and the floor is intact.
Yes.
In this posterior most part, what you see is the beginning of the inferior orbital fissure on both sides.
Yes.
Can you see?
Yeah.
Now going behind, see the changes. The septum which was going from the floor to the roof is thickening in the middle of the course.
Yes.
Can you see?
Yeah.
And the roof which is
Getting
from
flatter.
here to here, it is
now.
thinning behind laterally.
Okay,
It is
okay.
leaving laterally.
Okay,
And
yeah.
this roof is thickening in the middle with two thickenings in the
Lateral part. Yeah.
lateral part.
Yeah.
That is the beginning of the lesser wing of the sphenoid. That is the beginning of the rostrum of the sphenoid. And what you see at this level on both sides are the two pterygopalatine fossa. Can you see?
Yeah.
So that is just at the beginning of the sphenoid sinus. Now we see the next picture. Now we are in the sphenoid. Can you see?
Yeah.
We go 2.5 millimeter behind. Now see where the roof was gone. This is the lesser wing of sphenoid with
Yeah.
two interclinoid processes. And now no septum is going to the roof. Septum is ending here. And
Mm.
this is the intersphenoid septum with two sphenoid sinus. So that's how we can correlate how to where we are working and see the two pterygopalatine fossa. Now, lastly, the patient is almost ready. Last 1 minute in the sphenoid, the clinical relevant things. Once you see in the sphenoid, what we are scared of, what we need to know, what details we need to know about two structures. That is the optic nerve and the carotid artery. Now, see at this level when we enter the sphenoid, this is the orbital apex. Can you see?
Yeah.
Now going behind, see the two impressions coming into the picture. That is variable. That depends upon the thickness of the bone of the sphenoid. Sometimes the sphenoid is over pneumatized and whatever structure around in the sphenoid can be dehiscent. Sometimes the bone is thick, you may not appreciate even. So in this picture, you see there are two impressions superolaterally. Can you see this?
Yes, very well.
Just medial to the anterior clinoid processes that belongs to the optic nerve on both sides, and two impressions laterally. Can you see this?
Yes.
And in between is the clinoid process. Sometimes it is over pneumatized and you may have a bigger good opticocarotid recess. So this is the impression for the optic now, carotid artery, and what you need to see surgically relevant thing is whether they are dehiscent, they are prolapsing in the sphenoid wall, or any kind of anatomical abnormality in this region that you need to be careful during surgery. Okay?
Yeah.
And another thing you need
So
to
the
see whether there
demen,
is
the
lack of-
demen called Unedited you did not
Yeah.
discuss.
See, in all the cases, we'll see some of the positive findings on CT scan.
Mm.
So this is like I quickly went through. And lastly, what else you need to see in the sphenoid. Is there any lateral recess? So lateral recess is what? Pneumatization of the pterygoid process, which are extending from the body of the sphenoid on both sides and ending into the pterygoid plates, the medial and lateral. Can you see the pterygoid process here?
Yeah, yeah.
And this is not pneumatized.
Yeah.
You can see on the both sides of the pterygoid process attachment, this foramen belongs to the V2 and this foramen belongs to the VDN now. And see another thing, this intersphenoid septum, like any other sinus septum, is never in the midline. What you need to see, how it is extending laterally, like sometimes, it's like in this case, see posteriorly, it is going towards the optic canal. Can you see?
Yeah.
So in sinus surgery, we need to know all this, but it's not very relevant because we don't do any instrumentation with the intersinus septa. That is what the classical teaching is. We are not supposed to. So this is more relevant in the skull base. So this is all about the CT scan. Anything you want me to show?
No,
anymore?
now please
Or
go
any
wash
questions?
up.
Yeah.
Go wash up.
So
if
case
you.
is getting ready and Amol is with me. So I'm going to go wash up. For the wash up, now meantime we can discuss before we start. You can ask anything about the preparation part if I need to say, or if you want.
So you can go into a monologue while you're washing. What is your protocol?
Hello?
Yeah.
Can you hear me now from here?
We can hear you.
Yeah.
Yeah.
So preparation to me.
What is that
At
sound?
our
Are you
center,
washing?
We take care of certain things in the pre-operative period, particularly in the polyposis cases.
Yeah.
See, there are two varieties of.
So Satish,
sinusitis.
if you don't mind, can I ask Janki to point out something that he would like to say? Janki, anything?
Yeah, I think the few things which I think everything has been discussed by Dr. Satish, except that all my concentration will be towards the frontal because as a FESS surgeon, I am always concerned about the most difficult part of the surgery. And if you, I can't point, I don't have a pointer on a LED, so I can go here. Oh. Yeah, can you bring the scan there? So I think as any FESS surgeon, I think this is what you have to look at. So whenever you train your eyes should go towards the frontal. That should be your first checklist. And if you look at this very carefully, you can see that. Can you zoom into on this picture? This picture? This one? I'm running with it. Not that. Just come down, please. Second row, please. Yeah, thank you. Yeah, so stop. Yeah. See that this is the frontal recess. Okay. I always insist that you have this. This is the measurement, right? And you have the measurements posteriorly as well. So if you look at it, this is going to be the width in which you're going to operate. Okay. So, but this is going to be the width in which you're going to operate, right? So I always look at the width of this versus this. So for me, the right will be easier than the left. So this is one thing which you should always look at when you look at the frontal recess. And apart from that, I think everything has been discussed. And the way we deal with the scan, you will be seeing different varieties. But just one point to add that the left frontal is going to be more difficult than the right. It's going to be more difficult. That's it. So.
Hello.
Yeah, Satish. Yeah.
Yes. Thanks, Janki, for your input. That's true. What you said. So, what you want me to start with the left side, the difficult side? I would like to go by the difficult side first. The left one, if you agree.
Yeah, left. Let's start left. Let's stick to that. Whatever. I mean, it doesn't matter. Yeah.
We have to do both, and we can start from anywhere.
Yeah. But don't forget, now your surgical time starts. Okay.
Okay.
So 10 o'clock, 90 minutes. 91st minute, Janki is on air. Okay?
Okay.
Because this bonus you got because of the delay of anesthesia.
Okay, no issues, boss. You can stop me anytime.
No.
And if I would like to be reminded 10 minutes before, Ashish, if you can.
Okay.
So
we'll start the countdown. Yeah.
Yeah.
So it's 10 o'clock now, Satish.
10 minutes.
So 11:30, Janki will be on air.
So I have to do both sides in 1.5 hours.
No. You can do half the side in 90 minutes, but
okay.
91st minute we are going otherwhere.
Okay. No issues. We have to stick with that.
Yeah.
We appreciate
I think it's important.
So now coming to the preparation part, are you getting the endoscopic picture?
Wonderful, absolutely brilliant, wonderfully prepared.
Oh.
Compliments to Arvind and Amol.
Oh, they are
Well
superb.
worked out.
The best part about these Arvind and Amol is they never compromise with the quality. I've seen it set up
Yeah.
earlier as well with the equipments, instruments, every single
yeah.
small thing, they would never compromise. So I know Arvind, when he was practicing, he's practicing alone. Years
Boss,
back, he was one
Arvind's
of the
first cadaver FESS is done with me. And I could not believe that it was his first. I said, you bloody guy, you are lying the way he was doing it.
Remember he demonstrated FESS in Jaipur.
Yeah.
The way he did, amazing.
Yeah.
So
Now
now
there's some change that has happened in this. Earlier with Satish, used to pack that damn thing, for like 15-20 minutes, maximum packing. All that has changed. Now Janki will see your technique also. But now he just kind of is applying. He's actually not applying too much pressure on the merocell. As you can see,
Ashish,
it is, yeah.
like you mentioned, I always use the merocell for the reasons
Yeah.
that it is a soft thing, absolutely atraumatic. You can squeeze it into any narrow spaces you want,
Yeah.
and it opens up the spaces.
Yeah.
So what I do, I use two merocell pieces, two long pieces, divide into 8 to 10 pieces of different sizes. So I can use them according to the location where I want to use. Then you dip in the solution. I use only topical. I don't infiltrate at all.
Yes.
So I believe in the only topical decongestion, and there are papers. I've been following this for now many years. There is no difference in the overall bleeding, whether you infiltrate or not. If you decongest topically proper, that's good enough, and I'm happy with that.
Please
Now-
watch how he is painting everything that is going to come in the way of his endoscope. It's not just the target area. See, also the septum, also the inferior turbinate. So this is a secret that makes his field among the many things look so much better. See, otherwise we tend to go into the middle meatus and do only there. See, he's bringing in and out, and this is the application of the adrenaline-rich solution to the entire pathway of the endoscope and the instruments. Yeah.
Yes, Ashish.
Yeah.
So now, as far as the instrumentation you mentioned,
Yeah.
for the junior colleagues, just I would like to mention one thing here. Like I'm working in the left nasal cavity.
Yeah.
See my instrument here. My endoscope and instrument are converging.
Yes.
So they don't cross each other.
Yeah.
See, if I'm working on the left side, see how I'm stabilizing my hand. I'm pressing on the columella with a telescope.
So that we need
and
to see from
pressing-
the outside. Satish, we are
Yeah.
not able to appreciate
and
that.
pressing on the ella, you can see
Yeah.
with the instrument.
So
So I can converge. The next thing is, if I'm using instrument, if I'm going in, I will bring my instrument here and then follow with the endoscope.
Yeah, so he
if you are
brings the-
bringing out, follow
Yeah.
with the endoscope. So this should be the coordinated movement, which is very, very important. So we do everything under vision. We don't traumatize the opposing surfaces of the nasal septum and the turbinate, which can otherwise lead to synechia and crusting later on. That's very important in the post-operative period when you see the patient in the post-op.
Yeah. By
Now-
any chance, is the camera magnification slightly higher? Can you go to the lowest ring? Because
I don't know. I have a proper
no,
ring
this
on the
is
monitor.
looking good, but I was thinking.
I
yeah,
don't
okay.
know how to do that. Audiovisual
Okay.
guys are to our screen.
No. It's
is-
okay. No, sorry. I take it
Our
back.
picture is befitting on the screen.
Yeah. Okay.
I
We are
don't know what-
good too. We are good too. Thank you. Yeah.
Yeah. So this is all about the preparation. Now I'll skip the pre-operative part because of the time. Now what I am going to emphasize, that is very, very important, the intraoperative preparation. To me, there are two important things. One is the topical decongestion, like what I am using this merocell and soaked in the solution of 1 portion adrenaline and 4 portion saline. That depends upon the age of the patient. This patient is elderly, about 60, 70. So I am just using 1 portion adrenaline, 4 portion saline, and that too topical only. Now the other important part to reduce the bleeding. Why important it is? Because you need a good surgical field. If the surgical field is not good, you may not identify the landmarks properly, and then you can end up in complications. This surgery is the surgery of landmarks. We'll see how we pick up one landmark from another. So, other important things to reduce the bleeding, which I take into consideration. Number one, I ensure that the head end of the patient is raised by 15 degrees. That is 15 degrees reverse tendon position to facilitate the venous return. That's important. It makes the difference. And second thing is our anesthetist. See, there are a lot of talks about the hypotensive anesthesia. Believe me, I've gone through the literature many times, and now I've stopped looking at the blood pressure too much. it is the heart rate which matters the overall bleeding. See, if the heart rate, if you keep below 60, the venous emptying time is more, and then you have a overall less bleeding. You can even operate on the normotensive anesthesia. I don't ask in my anesthetist now to keep our blood pressure towards the lower side. Unlike in this elderly patient, anesthetist can't afford to do too low.
Who's
And
doing
he's
the
alone.
live streaming guy?
He's on the other side is a hypertensive patient. So I have not asked our anesthetist to reduce the blood pressure. Yeah, but it's very good. I am really grateful to our anesthetist to have given us a heart rate of 63. It's amazing. Hello.
Yeah, Satish.
So a lot of things are discussed about the blood pressure, Ashish. Believe me, nowadays stop looking at the blood pressure. Even I operate on the normotensive conditions.
Yeah.
The only thing I am concerned regarding bleeding is the heart rate.
Yeah.
Okay.
Okay.
Now, second thing, looking at the landmarks, you all know there is no need to say what is first part, second part,
Yeah,
third
no,
part.
no, yeah, please
So I am
don't say
coming
that.
directly to the middle meatus.
Yeah.
See now, this is the middle turbinate. What
Yeah.
we all need in the middle meatus is to keep the middle turbinate medialized. So whatever you operate in the post-op, you can advise irrigation reaching everywhere in the sinus cavity. Everything said and done well, and your middle meatus is blocked by the middle turbinate in the post-op laterally, everything can go as a futile exercise. So you need to ensure your middle turbinate stabilize along the septum. And the only thing I do, which works in over 90% of the situations, see what I am doing.
So all the way posterior, you're taking
Yeah,
your periosteum
inferiorly,
elevator
yeah.
almost to the ground lamella.
Yes, almost to the ground lamella, and I am giving little micro fractures to the inferior part. Can you see?
Okay.
Without destabilizing or doing anything with the superior part, this is literally called micro fracturing, which the surgeon can appreciate the clicks.
The crackling there.
Yeah, and see, once you do this and pack this with a Merocell for a minute, your middle turbinate will never come here and there during the surgery. That to me is one of the strategies, and to me this is my most common strategy to stabilize the middle turbinate medially. See, there are many ways. You can, at the end of surgery, you can bulgarize, suture, there are so many things, trim. You can trim a part of the middle turbinate sometime when it is very thin.
So
and
you
fluffy.
have widened your exposure to its maximum.
Yes.
So the overhang has been dealt
I
with.
want this turbinate like this
Yes,
to
at
be
the
there
end.
all
yeah.
the time so
Okay.
that I can see. Now, the important things about the surgery without wasting time. This is the uncinate process, we all know.
Yes.
This prominence belongs to the nasolacrimal system, and this is the axilla. This is the first part of the middle turbinate which is attached to the frontonasal process over here anteriorly and posteriorly to the cribriform we have seen on the CT scan at the junction of the horizontal and lateral lamella. Now this uncinate removal is the first step in any sinus surgery. See, this is bulla, this is hiatus semilunaris inferioris, and this is draining, leading laterally to this three-dimensional space, that is the ethmoidal infundibulum.
Yeah.
See, there are many ways to remove the uncinate, and I don't comment on this is right or wrong, whatever way you are used to.
No, but there are ways which are more
Yeah.
safer than the others. Yeah.
See, my technique is to use a reverse biting, go in the hiatus semilunaris, turn it little downwards. That is what's important thing I always ensure, and bite through. Don't remove that. Go further. This uncinate is little everted, you can see.
Yes, it is.
See, now I will go bite through until I reach the hard bone, then I will not do anything. Now, can you see something?
Yes, we can
This
see the.
step is known as infundibulotomy. This is opening the three-dimensional infundibulum. Can you see this?
Very nicely.
That is infundibulotomy. That's the simple step. And this infundibulum is the space where the sinuses drain into. So, see now another important, every time after every step, I make sure to ensure the mop with the
Merocell mopping
Merocell.
for the
This is I call as a magic Merocell. Believe me.
This you do as a routine in your surgery, or this is only
Yeah.
because you are demonstrating?
No,
so
no,
that
always. You have seen
Okay.
me operating, Ashish.
Yeah.
So many
No.
times.
I'm asking for the
Yeah.
sake of audience. Yeah.
Now see, this is the upper part of the uncinate.
Yeah.
Whatever I am showing, see, ours is a training center where a lot of junior trainees come, and we give them hands-on surgical experience as well. So the technique I am going to show is the most simplified version of sinus surgery, not like the sake of doing anything what you can do or showing off. This is simplest. So this is the upper part of the uncinate. This is the lower horizontal part. See,
Yes,
this
very
goes
nice.
behind to a variable extent. sometime
To
it ends up over here
to
in the
the
mucosa,
fontan.
and sometime it goes up to the perpendicular plate of the palatine bone.
Oh.
Now what I am going with my ball probe, I am fracturing the lower part.
Hmm.
The important thing is not to strip off the maxillary sinus wall. So what you need to do, keep the ball probe upturned. See, gently, gently, you can fracture it to see the the maxillary sinus ostium. Now see, if I suck in this region, you will appreciate. Can you see?
Yeah.
Can you see the maxillary sinus ostium?
Very nicely we can see.
Now,
Yeah.
I can do so many things over here. See, this lower part of the uncinate, the horizontal part of the uncinate, is surrounded by the mucosa on this side and that side.
Yeah.
A lot of people remove this medial mucosa, remove the uncinate, and outturn this thing like turn out the mucosa outwards and name it as a flap. I have seen hearing from people, they've given it names from their city like Jaipur flap, Bombay flap, Bangalore flap. I really don't care about this thing. It hardly makes any difference.
Meatoplasty.
Yeah, my
Mucosal
simple
line.
technique is not to fall into all this difficulty, and I can debride this uncinate, I can bite through this uncinate. See, the instrument I am using, which I like in my practice, that's the same thing I am doing, is the micro debrider. Got my point?
Yes, yes.
So you can remove the medial mucosa, remove the uncinate, and evert the lateral mucosa. You can do that. There is no harm in doing that. But believe
But
me,
there is no
need
outcome.
to,
It does not influence the
yeah,
outcome.
hardly anything. If you give a good size middle meatal enterostomy, it hardly affects, because our philosophy is to follow all these patients post sinus surgery with the irrigations. See, this is an inflammatory disease which requires steroids for their overall good outcome. And if you give a good steroid irrigation, no sinus gets stenosed. That's the important thing. So we believe in that. So
Satish, in this step, is there anything that you can harm? I mean, anteriorly
Yes.
you said the
Yes,
nasolacrimal.
yes, very
Posteriorly,
important.
is there something here?
Yes, Ashish. The only important thing in this step, why we opted this one? Because if you use uncinate, you have a fear of entering the orbit. Sometimes the uncinate is closed. So, in this step, the only important thing is to take care of the nasolacrimal system.
Yeah.
That's why I told that you bend your reverse biting little inferiorly. The nasolacrimal comes like this. And the uncinate goes like this.
Yeah.
So if you bend it inferiorly, you stay away from
Farthest
the
away
nasolacrimal.
from the okay.
And the nasolacrimal system. That's the important thing.
Yeah.
Second thing is, if you come across any hard bone while biting through, see, this nasolacrimal system is composed of 3 bones. The thickest one is this frontomaxillary process, the other one. So if you come across a thick bone, you need to stop and see that you don't bite through the nasolacrimal system. Now what I am doing,
posteriorly you can go as much as you can.
Posteriorly you can go. See, there are 4 types of middle meatal enterostomies. This is what I have done as the simplest one. Now there are other 3 varieties of middle meatal enterostomies. If I flush this medial wall, remove this completely and flush with the posterior wall behind, that is a little bigger type 2 middle meatal enterostomy. Can you see this?
Yeah.
If there is too much of disease, I need a mega enterostomy for the future surveillance and irrigation, like massive fungus and massive diseases, which is not there in this case.
Yeah. At this point, Satish, if there were Haller cells, would you deal with them now, or you would remove them?
Not now. But yes, I will appreciate first on the CT scan.
Yeah.
And then I'll keep in mind to deal with that. Straight for second.
Okay.
See now, Ashish, the
Yeah.
important thing is the marrow cell. I kept the marrow cell for a second and see the field. Every time use it, see this?
Yeah.
And your surgical field, you
Yeah.
can check all the time. That's the most important, I would say,
Yeah.
the thing to
Yeah.
prevent the complication, to have a good
So
surgical
me and Ashim, we joke about you, Satish. Your fresh cadavers bleed and your patients don't bleed.
I don't know.
Your life.
I am thankful to the anesthetist here, the Arvind preparation. But surely, that's the message I would like to give. Stop injecting. If the injection or an infiltration goes in the systemic circulation, it can give you a nightmare.
Yeah. Okay.
There
So
are
now
reports-
elaborate on this, because
Yeah.
very important step for
See now,
frontal now.
The upper part
Yeah.
of the uncinate. Again, you have many ways to remove it. For the junior colleague, the simplest way is go in the hiatus seminaris. See the bulla behind? Go into hiatus seminaris with the angled probe. Go high up and you can fracture your...
And he is mobilizing it to its anterior most limit.
Yes.
Gently there are strokes and you watch where the mucosa will stop moving.
See this?
It's draped
Now-
on the thick wall. Yeah.
Now you can take away by the through biting. You have many tools at every step. But here I again simply use the micro debrider.
Because it has got mobilized, now it gets sucked into the debrider, and therefore whatever can get sucked, only that can get debrided. So that's the
And the best thing
fantastic.
about the use of debrider is don't press anywhere.
Yeah.
It will not work. See, just go close to it, and your blade will cut and suck. You don't have to go.
Yeah.
Now, what I was trying to say, this upper portion of the uncinate, can you see?
Yes, very
It
nicely.
forms the medial wall of the agar neji. This is the agar neji.
Open now. Yeah.
So that's very important. I will go right up to the axilla.
Right up to the axilla, up to where the debrider can debride, right? Where it stops debriding, you stop.
This hard bone cannot be debrided.
Yes, so up
That
to
is the
where
point
it can
where you have to
debride,
stop.
yeah.
And the most important thing in the entire surgery, believe me, see
Now
why
the
we are
lateral
doing
wall,
FESS.
yeah.
Why we are doing FESS for the resumption of the mucociliary activity. So you need to preserve the mucosa. Chota mera cell hai. So everywhere you need to spare the mucosa from stripping. That's most important. It should leave like a completely mucosalized cavity at the end of the procedure.
So the walls of the sinuses should not be stripped. Obviously
Yeah.
not the air cells. So
That's
it's
the
the
thing.
wall. So the lateral wall, he's making sure he's not going to strip the mucosal blanket.
Anywhere
Yeah.
in the sinuses.
Yeah.
And debrider here scores over the other instrument, as it is a sharp cutting instrument. It doesn't peel off. You need to have a good section backup. Keep the debrider close to the structures, and then you use it gently, and you will never strip off anything. So that's what we want: the mucosal, complete mucosal lining the sinus in the sinus cavity, so that the mucociliary activity can come back. Can I do a white balance?
Just to help you with the time audit, we have 15 minutes. You have a lot of time, but just telling you in terms of milestones.
You tell me
Yeah.
20 minutes. If I
No. We have 15
Before-
minutes into the surgery, is
Yeah,
what I am
so
telling
I
you.
will
Yeah.
finish off the other side in 10 minutes. Don't worry. So we can demonstrate properly on one side. We have both the options.
Yeah. No. Yeah.
Now see
So
what
now,
I'm trying to
yeah.
show.
So now
I've changed to
we
a
are seeing
70
the
degree.
lateral limit. We are seeing the
Ashish,
lamina. Yeah.
I've changed to a 70-degree telescope now.
Yes.
This is the telescope of my choice for the sinus surgery. For
Yeah.
any sinus surgery, if I am given a single telescope, I'll opt for 70, not for 0. This is the most versatile scope. Of course, for the junior colleagues, you need to get used to this 70-degree telescope, because your optical distortion is something which you need to overcome by means of getting used to it. That's I would say a learning curve. But see why I said versatile. See,
Yeah.
if I make it horizontal, you can make it even 120 degrees. See the entire roof of the
Yes.
anterior nasal cavity, anterior most. But if I make it vertical, can you see this picture?
Yes.
I
That's
can
was
make
zero.
it 0 degree as
Yeah.
well. I can go into the nasopharynx anywhere and make it 0 degree. So this is the most versatile scope, I would say, in my practice. So in my practice, I generally use most of the time when I'm not demonstrating, of course, but doing, I most of the time do with a 70 degree only. And that is so versatile, you don't need to change the scope, you can go anywhere. See now, if
Yes,
I
the
rotate my
maxillary.
cable,
Yeah.
you can see inside the maxillary sinus as well.
Yeah.
This maxillary is little
Healthy.
bit edematous mucosa, so I'm
But-
not going to widen it
Yeah.
anymore.
Yeah.
I don't see any need of doing anything like that. Now, at this point, what I was waiting for, the marrow cell mop. Now see with the 70.
Yeah.
Why I opted 70? This frontal sinus, see, after the uncinate process, my next target is the frontal sinus.
Yeah. So
What I want, why I want to go to the
show the
frontal
bulla properly, the anterior wall of the
Yeah.
bulla.
This is the anterior wall of the bulla.
Hmm.
And that is the agar neji.
Yeah.
Can you see?
Yeah.
And that is the lateral
Lateral
wall.
lamina,
That is
yeah.
here is the orbit.
Yeah.
You can see. So why I want to go to the frontal first? And reason being, if see whatever the learning curve is, you have to overcome your challenges. The challenges in the frontal sinus for anybody are 3. And that's why people are always scared of doing frontal sinus work in the beginning or even in the late career, because of number 3 challenges. Number 1 is the damage due to the close proximity, the damage to the skull base. Can you see that?
Yes.
Up there medially skull base. Second challenge is damage to the orbit.
Yeah.
And third challenge is the anterior ethmoidal artery.
Yeah.
See, over the period of time doing sinus surgery in last 12 years, having done around 7,000 cases now, we have seen all kinds of failures and complications, which is unbelievable if I say. And we have overcome all those, and the technique we have developed, and in last few years not seen a single complication, is this, the use of 70 degree. The hallmark of this technique is the use of 70 degree. The reason behind is, see, this is the middle turbinate we have seen going up to the skull base. Okay, if I keep my middle turbinate all the time in view like this, can you see?
Yes, very nicely.
And stay lateral to it.
Yeah.
Ashish, how can
Yeah.
I damage the skull base there?
Yeah.
And enter into that? So this is possible only if when I am working all the way with a 70 degree, which can give this kind of visualization all the way right up to the end. Okay. Similarly, if I keep my lateral wall, the orbit in view all the time, and stay lateral to it, simply I can't damage anything into the orbit. Third is this bulla. This bulla is one structure, if you see, and if I tell you in our experience, over 98% of the time it goes up to the skull base, and I'll show the attachment where it goes up to the skull base, and wherever it gets attached onto the skull base above, the anterior ethmoidal artery is just behind that. So bulla automatically covers the anterior ethmoidal artery. So as long as you keep the bulla intact and stay anterior to it with a 70 degree, keeping your medial and lateral limits in view, you practically don't damage anything. Are you getting what I'm trying to say?
Yes, yes.
So simply what I'll do, see there are...
So now the surgical landmark, actually it's the middle turbinate that is guiding you towards the...
Yeah. So now what to do in the frontal recess, you have to get to know first through the CT scan the kind of cellularity there. Now there are cells, the kind of cells which are attached in the frontal, there are two types. The cells which are attached to the anterior wall of the frontal recess. Frontal recess is not like a duct, it is determined by the anatomy of the surrounding cells. So there are cells which are attached to the anterior wall of the frontal recess, and there are cells which are attached to the posterior wall. And you need
so
to
now
know.
you are with a rad 60 blade, 70 degree scope, looking up, you have fractured the agar and the and
the
your
medial
debriding.
wall of the agar.
Yeah.
I have fractured the medial wall of the agar. I am staying medial to the...
Yeah, just lateral to the middle turbinate.
Yes.
And between that and
See,
okay.
this agar I have fractured many ways to remove it.
Yeah.
I can remove it by many ways.
Yeah,
and
you
see
can
what
see
you have
the
seen.
frontal. Yeah, yeah.
See all the way.
Yes.
What you see
already,
is the middle turbinate.
Yeah.
I am not interested in looking for the frontal from beginning.
Yeah.
My interest is to keep an eye on the limits.
Insertion of the
If
mid.
I keep an eye on my middle turbinate and stay medial to it, lateral to it, I am sure I am not going to damage anything. Now see, you can see your frontal up.
Yes, nicely already.
And this is the supraorbital recess.
Fantastic, yeah.
And
that is that interfrontal cell in anterior to the...
We'll see later. I have to take into consideration...
Sorry, I'm just trying to appear intelligent here.
You are. Don't say that you are not. Now see,
Yeah.
I've removed this fractured lamella, and now I will see, this is the simplest version which we have developed and we have shown in our course.
So let's use the word Satish safest. Because this is protecting the anterior ethmoidal.
Everything.
Because simple is a matter of training. Yeah.
Ashish,
Yeah.
The moment you cross your limit,
Yeah.
you can land up with complications.
Yeah.
If you stay within your limits, you can't simply. How can you? See now,
Yeah.
my lateral limit, after removal of this cell, the microdebrider.
Yes.
You see, my lateral limit, that is.
Beautiful. Absolutely. Super.
Lamina.
Yeah.
See now my lateral and medial limits in view.
Yes. Very well seen.
Clear?
All
Now,
three borders. Yeah.
120.
Medially the middle turbinate, laterally the lamina, and
If
posteriorly.
you see your limits, don't cross these limits and go into the frontal. There is something I would say, how can you damage anything in this region? What is the fear which is
Okay. Is there anything you've done to change the position of the head? Have you
no,
given nothing?
Sometimes
Yeah.
you may have to remove this flexion
Below.
a little bit.
Yeah.
Sometimes.
Sometimes.
But
Okay.
generally I don't do. I use, rather than doing that, I use a 120 blade to work far anteriorly if I need to.
Okay. Can we see
What?
it being used at some point of time?
Yes.
Whenever.
Just now
yes.
I am showing you.
Okay.
Now Ashish,
Yeah.
you can sometimes see the multiple openings in this region.
Yeah.
Can you see that?
Yeah.
sometimes multiple, sometimes like big supraorbital cell, intersinus septal cell, and you can easily get carried away that this could be the frontal. Sometimes the frontobular, sometimes the type 3 cell. So how to identify for sure that in between these two limits, what you are seeing is the frontal. Getting my point?
Yes, yes.
I'm exactly between these two limits.
Yes.
Now, my most important limit, which I always respect as the most consistent landmark, is now going to come. So, why it is coming later? Because I want to ensure my medial and lateral limit, and once you ensure your medial lateral limit, work in between. Now, this is your beak, you see?
Yeah. So this is a 120?
Yeah, this is 120 for working anterior. Why it is not working? What? नया नहीं है? भाई, क्या दिया यार? नहीं, this is partially clogged. Looks like partially clogged.
Is there ever any cell attached to the beak, or the beak is just the
there,
dense
no,
bone?
there are some interethmoidal cells in this region. So you need to flush. What I am trying to show is, see now the longer probe. See the beak we have seen on CT scan. We'll know this beak floor forms the floor of the frontal. Okay.
Yeah.
At the same time, it forms the anterior wall as well. The frontal is behind this.
Yeah.
So, if you follow the beak, where it is going to end? See this
In
beak?
the frontal, yeah.
See this thick beak. If I follow it, where it is going to end? See this.
Yeah.
See
So,
this
so
part.
this I believe will be more relevant in revision cases when you don't
Everywhere.
have the
See, boss, I have done so many number of revision cases that the only landmark which you will always find in this region, you may have middle turbinate out, you may have the lamina deficient, you may have the
bulla
skull
gone,
base not
course.
identified, everything. The only landmark which you always see is the nasolacrimal system and the beak. I have done 19th revision of a patient, operated so many times everywhere in the country, but this region is always intact. And this only single landmark can take you to the frontal easily. Can you see this?
Yeah.
If you follow the beak, you cannot go anywhere. You will go directly into the frontal if you follow it behind. Now what I am doing is, see, I can see my medial and lateral limit. Now see my anterior limit. Can you see that?
Yes.
This is my frontal sinus visualization. Can you see? Now see medially there.
Yeah.
Into the frontal sinus. That is intersinus septal cell going medially. Can you see?
Yes, we can see it very well.
See, don't get confused with the intersinus septal cell from the beginning that it is going to give us a tough time. It can. But you need to know what is this cell. This cell always opens in one of the frontal sinus. So why are you bothering about that cell unless you reach the frontal sinus? This is not going to open in the frontal recess directly. This is going to open in one of the frontal sinus, and you can easily pick up once you see the frontal sinus. Go medially and look for the cell. Got my point? Hello?
Yeah. Sorry, I'm reading something. Yeah.
So you can easily pick up this cell in this region. Watch. See, again my marrow cell to show you. Now the biggest question comes in this region is how much to widen the frontal sinus. Okay?
Yeah.
See,
Just Satish, one minute. Live streaming people, I forgotten your name. बेटा तुमचा व्हॉइसची कंप्लेंट येत आहेत. पीपल आर सेइंग सो इफ यू वॉन्ट टू इन्क्रीज द व्हॉइस, those who are doing live streaming, if you can do something to the voice. The picture quality is very good, but the voice they want better. So if you want to get the voice output from the audio, from the OT, please go ahead, do that. Yeah, sorry Satish, we are back with you.
Yeah. No issue. See what I have done is the irrigation.
You have flushed,
so that it takes away the blood stains and makes your
field look better. Yeah.
Can you remove this?
Okay, so once we open a frontal, should it always be to the widest possible limits, or is there, like you said, 4 types of maxillary ostium opening things?
Yeah.
Can we be?
One. Yes, Ashish, your question is valid.
Yeah.
See, to me, if you are asking me, the commonest cause of frontal sinusitis, I tell you, is iatrogenic. If you are working in the frontal and if you are leaving the cell and septa behind, the fibrosis scarring can bridge that and can lead to restenosis. So our philosophy is, that's what I was telling you, that the biggest question is how much the frontal to be widened. to me, there is a simplest answer to the limits. If you are working into the frontal,
to its maximum anatomical limits.
yes.
It's
So,
not a question of 3 millimeter, 7 millimeter. No.
I have seen the reports, people telling if the final frontal sinus ostium size is 9 millimeter, it is unlikely to stenose. It doesn't work like that. So the size you are measuring is just like a monkey business, I tell you. It cannot work.
It should be mucosal lined.
Yes,
That's the key.
the only important thing is you need to exenterate all cell this in this region. Number one, it should be completely mucosalized. If you strip out the mucosa, that fibrosis and scarring that ensues later on is the big trouble.
Okay.
That is inevitable.
Point well noted.
And number
Okay.
3 is, if you leave the septa, that can be bridged by the scarring and all. So what you have to do is now with the 70, my lateral limit, can you see?
Yes, very
The
nicely.
lamina all the way.
Yes.
My anterior limit, you can see the beak.
Yeah.
My medial limit, you can see the middle turbinate. And my posterior limit, you can see the posterior table under the skull base. Can you see? Can I go beyond anywhere?
Yeah.
If I try to go beyond anywhere, I'll have to face the tough time with complications. So, this is the way, if you are dealing with the frontal, see,
Yeah.
and enlarge it, completely mucosalized, you can see, and a single millimeter of mucosa not stripped. And
Yeah.
that's what we aim to do. Keep it completely mucosalized. Keep your visualization good by means of mopping in between the marrow cell, and see how marrow cell it works. It's so atraumatic. It's not adding any extra cost. I'm going to use these marrow cell pieces to pack in the ethmoidal cavity at the end of the surgery with no
Yeah.
extra cost. So the same marrow cell being used again and again. We are removing it, rinsing in the saline solution, and dipping in the same 1:4 solution and using it again and again. Okay? Okay? That's about the frontal. That is intersinus septal cell, and that
Satish.
cell behind it. This is
Yeah.
supraorbital recess. What we
Yeah.
appreciated.
Yeah.
Now, Ashish, sir.
Satish,
Yeah.
now of course, Lord, you are very versatile in using a 70-degree scope. There are a few people who do struggle to use this. What is your comment on Wormald's auxiliary flap and using a 0-degree?
See, that technique was developed by the people earlier
Yeah.
who were not good with 70 degree.
Okay.
One cannot replace with 70 degree. The science is evolving, boss. If
Yeah.
something works better,
Yeah.
you have to accept it.
Okay.
I'm not saying that is wrong or right. I'm not falling into any
Can
controversy.
I make my humorous way? The axillized forehead is a very ticklish area.
And sometimes
so,
it leads
so
to
that flap,
horrible.
I think there is something in that flap. Maybe you probably tried the axillary flap, Janki? Yeah. So you want to make any comment about sometimes you can go wrong with the flap or not?
Ashish,
Are there some secrets about the flap? Yeah.
Ashish,
Yeah, Satish, 1 minute. I'm asking Janki to comment on the flap, and then he's going to move to the OT now to look at his patient.
now
Yeah.
see what I'm doing. That's the most important step in this surgery. A lot of people have queries regarding anterior ethmoidal artery. I mentioned you why I intentionally. Oh, Janki was commenting something. Sorry.
No, it's okay. It's okay.
No,
He
no,
stopped.
Janki,
You
carry
go ahead.
on.
Go ahead. Don't worry. We will talk. Yeah. Okay.
We'll have his
Acha,
input
ek
throughout the
minute.
day.
Ek minute. Let him speak about the axillary flap.
Yes,
Because
please.
he interacts with Peter Wormald.
Janki, feel free to interrupt any time.
No. I think it's perfect. Axillary flap is one thing which I don't do. So
Fantastic. We don't need to do. When you're with the 70, you don't need to do. That is the truth.
Ashish,
And
if
that
something
Richard
is-
Douglas, I think he
Ashish,
was. Yeah.
If something is good,
Yeah.
maybe difficult to do,
Yeah.
I'll opt for that.
Yeah. Sure.
See, I need to
Acha.
have some drive to do that,
Yeah.
giving some good additional
Of course, there
advantage
has to
or
be a
outcome.
value addition in
Yeah.
doing something.
Then
And why
everything is
violate
secondary.
an anatomical structure?
Yeah.
And
Then everything
mucous-
is secondary.
Yeah.
Okay?
Satish, please tell Arvind or Vivek, send the car for Janki.
Yeah, boss.
He's going
Hello.
He's going to come there and look at his patient now.
Yeah.
Okay.
Ashish,
Yeah. So
Now-
please announce when the car is here or when they leave it.
Arvind, coordinate please.
Yeah. Because he's not picking up the phone. So sorry.
बहुत काम है उसको यार.
Okay,
So,
Satish.
Ashish,
Sorry. Go ahead.
Yeah.
Go ahead. Yeah.
Now, the third thing which we discussed about
Yeah.
anterior ethmoidal artery preservation or this intact bulla technique is, I said as long as the bulla is intact, the anterior ethmoidal artery remains behind it. You know? Hello?
Yeah.
Now see how it protects the bulla. See what I am doing now.
Yeah.
This is the bulla now with the 70 degree. Can you see?
Yeah.
So
Okay, now this is where he's changing. Again, this is something change which he has brought. He's
See
going
now.
to do the next steps of the bulla removal also with the 70.
yes. See now why I was preserving the bulla.
Yeah.
Assuming that my artery will be protected by the bulla. Now if I go behind with the ball probe, see how the bulla is removed. Go behind the bulla.
Retrobullar as superiorly as possible. Boom!
Now,
There it is.
Can you see something?
Not something. We can see it.
Can you see?
Yes, sir.
See now how well protected by the bulla.
Yeah.
Why I need to be concerned with the anterethmoidal artery all the time?
Yeah.
That's the simple thing. This is the simplest way for the junior colleagues. Don't be so scared about the anterethmoidal artery. Stick to your landmark. Stick to
And-
your.
And now that he has seen that artery there with the bulla there, now the bulla theoretically we call it the garbage.
Yeah,
now
obviously it has to be
now you
removed.
can
It has no
screw it
sense.
whichever way you want it.
Now, Ashish,
Yeah.
another thing which I mentioned in the beginning.
Yeah.
See where the bulla gets attached to the skull base. See high up.
Yes.
Can you see?
Yes.
The bulla
Can you
gets attached to the-
debride a little bit of this
Yes.
anti-rage? We'll be able to see it better.
See
Yeah.
this. So, yes, your point is good.
Yeah.
So, this bulla goes high up on
Achha,
the skull base.
ek minute
See
na,
the upper
Satish.
part of the bulla.
Ek
Yes.
minute, Satish. That external camera, just some people want to see the stability of the scope. Yeah.
Yes.
So just make that
Yeah,
point what
external
you are
camera,
making.
please.
External camera, zoom in
Can you
onto
give a
the.
PIP or something or zoom
Yeah.
in?
Okay.
Can
Yeah,
you
so
see
that's
what I'm doing?
It's like the billiards stick that you hold. I don't know what it is called, but that's how it is stabilized at the cue. Okay.
See now, if I remove this anterior part of the bulla,
Hello.
Just to
Sorry,
show-
sorry. You have to just show the stability. Okay. Okay.
see now,
okay.
what I'm trying to show is where the bulla goes up to the skull base. Can you see this?
Yes. Very
the upper
nicely.
part of the bulla
Yeah.
going to the skull base, where anterior to this artery.
Yeah. Yeah.
It
Yeah.
should be very, very clear with no confusion.
No
That
confusion.
bulla goes up to the skull base, just anterior to the artery.
Beautiful.
So if your bulla is preserved and work anterior to it, you cannot damage the anterethmoidal artery.
Yes.
I hope it is.
It is beautifully seen. Thank you very much.
So now I like Ashish, how you said.
Yeah.
Now this bulla is a garbage.
Yes.
We can remove it, and the only thing which has to be careful is the
Lateral
lateral
limit.
aspect, because
Yeah.
the lateral attachment of the bulla is the lamina
Lamina.
papyracea.
And
So-
that's what you ascertain that it is not
Yeah.
eroded in this
Yeah.
pre-op
So
CT.
anyway, I am not going to press upon the
Yes,
lamina. I
yes.
told you the strategy is the debrider
Yeah.
should go close and
Go
debride.
close and the angle,
Don't press
it
on the
should not be
debrider.
facing the
Debrider
lamina.
is a great tool, but it can be hazardous if it is not used properly. See, your cutting edges should be under vision, under close-up all the time.
And you are with a 60 or a 120 still?
60,
60, yeah.
Now see the better picture of the
Anti-ethmoidal now.
anterethmoid as well as the lamina papyracea.
Yes, very
And see,
nice.
it is fully covered by the
Mucosa.
I am
Yeah.
not pressing on the anterethmoid at all.
Yeah,
Can you see?
very nice. Can you mop a bit?
Yes, I am going to. Now, reverse. Another important blade which I am going to show you, which I work at the skull base,
Yeah.
is the adenoid blade. Believe me, I call it as a skull base blade, never used for adenoid. I condemn this blade to be used for adenoids. That's a rear facing blade.
Then why did you buy it for adenoids?
Never. I never use it for adenoids.
Yeah.
I have written to the Medtronic twice to change the name of the blade. It has an amazing ability to work at the skull base safely. Adenoids I condemn because it's a posterior facing blade. The first principle of the debrider is to keep the cutting edges in view. Now see, again, the frontal sinus, see this
Super.
fovea and the supraorbital recess,
Yes.
the artery behind, and that is the upper attachment of the
Bulla.
bulla. Now what I am going to do,
Very
see
thin
now,
ledge remaining.
yeah, that I am going to remove with this reverse blade. Anything on the skull base at this level. See, with the 70, my rear facing blade becomes the front facing. Can you see?
Hmm.
My cutting edges are in view. You can't do with your regular blades in this angle.
Yes.
See,
Beautiful.
that's the advantage of the reverse blade, the adenoid blade. Now see your anterethmoidal artery completely, your septa completely flushed, and everything mucosalized. So this ends up my anterethmoidal work. This
Beautiful. Yeah.
your maxillary.
So what you did just now with that 40 reverse,
Yeah.
is it kind of mandatory or obliged to do that much of a finishing?
Yeah, I need to that because of my irrigation. Irrigation is we are going to discuss later. See, this role of sinus surgery is now merely more and more to give
It's
access
beyond
to the
ventilation going into irrigation.
irrigation.
Yeah.
So I need to give full access to the irrigation. If I leave some septa, my irrigation may not reach the supraorbital cell or something.
Satish,
like
how do you know that is the anterethmoidal artery?
Yes, it is. See the coning of the orbit.
Yeah,
See
no,
the
no.
supraorbital recess.
Yeah.
I told you that the same thing during the CT scan. The advantage of supraorbital is very important. Dr. Deepak Haldipur pointed out that time. The importance, the positive importance is if you see the supraorbital cell, the anterethmoidal artery is going to be immediately caudal.
Yeah.
See that?
Yes.
So this artery is basically pushed by the over-pneumatization of the supraorbital.
Pushed
At-
by the over-pneumatization of the
Supraorbital
supraorbital.
behind.
Behind. Okay.
So this is always variable. Sometimes this supraorbital is not over-pneumatized.
Yeah.
You may have a small fovea, one cell over it, and the anterethmoidal artery would have been here. So this location of the anterethmoidal artery from this point of view is variable. The only constant way to find the anterethmoidal artery is that now I am going to show you. I told you the upper attachment of the basal lamella. That is to me is the most constant landmark to identify the anterethmoidal artery. Okay? Now I am going to change for you to the 0 degree. Hello?
Yes, yes.
Are you with me?
We are with
Yeah.
you.
So straight, substrate. Wait, Sandeep, सीधा हो जाओ. So now I am changing to irrigation. Surgical field is the most important determinant in terms of avoiding complications. If your surgical field is not good, see everywhere I am only concerned with the landmarks. It's a regular. So I am concerned with the landmarks. Every time I need a new landmark to go ahead. Got my point?
Yes.
Now see, I changed to 0 degree for better orientation for everyone. Now what you see here now, so far, that's your anterethmoidal artery. Hello?
Yeah.
Zero. Now the lower down is the inferior remnant of the bulla ethmoidalis, which I am going to take away. Okay?
Hmm.
Ashish, you asked me
Yeah.
when to deal with the Heller cells.
Yes.
This is the time when I deal with the Heller cell.
Okay.
Now see, it looks like a small Heller cell as
Yes.
well.
Yes. It's
So
just
this
about
is the time. There is see in this technique, you don't leave anything. There is a systematic way of dealing with each and every area of the sinus. Can you see that?
Yes, very nicely. थोड़ा कैमरा को सीधा करो.
Yeah. Some irrigation work is channel is being sorted out. Yes. Now you see.
Yeah.
So now what you see the next structure in front of you after removal of the bulla.
Ground lamella.
So we went in the retrobullar recess and got the bulla out. Same way going behind it, got it out and saw the anterethmoidal artery behind. Okay, this is anterethmoidal artery.
Yes.
I tell you, I will reiterate my junior colleagues, 100 times the best way to identify in the difficult situation the anterethmoidal artery is what I am going to tell you. See, this is the first part of the turbinate. This is turning, going to the lateral lamina papyracea. This is the second part of the turbinate. Can you see?
Yeah.
That is ground lamella. And where the ground lamina is going up on the skull base. Can you see?
Yeah.
Where the ground lamina is attached.
Yeah.
If you find the ground lamella, the anterethmoidal artery is few millimeters anterior to it.
Oh, that is 1
This
centimeter.
relationship will never change. Ashish,
Yeah.
if anybody is finding difficulty, if there is too much of disease there and scared of the anterethmoidal artery, just find the ground lamella, see the upper attachment, and the anterethmoidal artery is almost always immediately anterior to it. This relationship is never going to change. The relationship of the supraorbital cells and other things are variable. And to me, if you ask the single most important landmark for the anterethmoidal artery to be identified during surgery.
So, but there can be many cells, no, between that and the artery, or there's only one cell?
One cell, sometimes two cells, sometimes a huge supraorbital cell, sometimes there is hardly any cell and artery is immediately behind the frontal recess. So that can be variable.
No, I'm asking as a relationship to the ground lamella.
Yeah.
So you're saying the superior attachment of the ground lamella.
Yeah. Please. What you are asking?
So between the ground lamella superior attachment and the anterethmoidal artery, there is always one cell, or there are many
Yeah.
more cells?
No. There is a,
This
as such no cell. This is the space.
this
you
is
can
a
say.
space. Okay, there is
It
no
will
cell.
always see like this. In all our cases, I am going to show this. This is one of the most important landmarks. Now, Ashish,
Yeah.
most important thing called section. Now we have to need to go behind the ground lamella.
What happened to Janki's car, please, Arvind? Yeah.
It's coming.
Sorry. Yeah.
It's gone. So, Ashish, now
Yeah.
the two things left. We have done maxillary, anterethmoid, frontal, and we have developed our corridor. Can you
Yes.
see the corridor?
Yes. Beautiful.
Mucosalized corridor between the lamina and the
Middle turbinate.
middle turbinate.
Yeah.
Now, what we need to do next is the only work left is the posterior ethmoid and the
Sphenoid.
sphenoid sinus. See, believe me, the most dangerous thing to do in the sinus surgery or most potential step to give complication is the posterior ethmoidectomy. Most dreaded complication in sinus surgery happen to occur during posterior ethmoidectomy. The reason being, the only single reason is surgeon doing posterior ethmoidectomy sometimes is not aware of the posterior limit of the posterior ethmoidectomy and accidentally enter into the sphenoid sinus behind.
Yeah.
And if you don't realize, keep working, assuming posterior ethmoid, you can hit the optic nerve and carotid. So the technique which I am going to show for the junior colleagues, if you follow this, you will never damage. So what you all need to know, number one, why I clear the infraorbital cells at this point of time, Ashish,
Yeah.
to know one landmark. I told you this is the surgery of landmark. You have to move by the landmark. See the roof of the maxillary sinus I want to see.
Yes. Now this is very, very important, I think, surgically to identify not just the uppermost level of the your maxillary ostium widening,
Yeah.
but you go to the roof. The landmark is the roof of the maxillary sinus, the
So
superior
simplest
wall.
way for our colleagues, this is the roof of the maxillary sinus.
Yes.
And to delineate that, I clear my infraorbital cell at
Yes.
this point of time.
That is why he got the halars also out.
Yeah.
And now
So
that's
I
the
don't
line.
look for the halar in the beginning
Yeah.
and confuse yourself. Just leave it and come to that point at this point of time. Okay? That
Yeah.
makes your life so easy.
Yeah.
See now. So why I identified this maxillary line? I told you this is a surgery of landmark. The moment I find a maxillary line, this is a very, very important landmark for me to work behind. Because what I need to know, as I mentioned, I need to know before doing posterior ethmoidectomy, my posterior limit of posterior ethmoidectomy, so that I don't accidentally enter into the sphenoid sinus. So, first of all, you need to enter into the ground lamella, and here my maxillary line is important. See the upper border of the maxillary sinus?
Yes. Very nice.
Medially into the ground lamella, where the first part of the turbinate turns into the second part.
Okay.
Here I
So
will-
wait a minute.
Yeah.
Before you go there, where should you not do it? Tell me. Commonly
Yeah.
where do
Okay,
people
okay,
go? Yeah.
okay, Ashish.
Yeah.
If I go there little above,
Yeah.
you know where I can go?
Yeah. Skull
See
base.
what
Yeah.
is there?
Yeah.
So you have to stay inferiorly.
Okay.
See now,
Yeah.
I entered into
Zero.
the lamella.
Mm.
Now what you see behind is the posterior ethmoidal cell. I told you,
Superior
I am
turbinate.
scared to do posterior ethmoidectomy unless I know where is my posterior limit. So see now, what I told you during CT scan, the moment posterior ethmoid starts, it is bounded medially by,
Superior
this
turbinate.
is superior turbinate. Can you
Yeah.
see?
Yeah.
I am trimming off the lower one third of the superior turbinate, and see where I am working between the superior turbinate and the septum. This is my nasal septum.
Yeah.
So if I trim the lower one third of the superior turbinate and go in the front sphenoethmoidal recess behind, see that what I am wanting before doing posterior ethmoidectomy. These posterior ethmoids are intact.
Yes.
What I am wanting to
No.
know, to have a landmark,
Anterior wall. Yeah. Okay.
to have a landmark which tells me this is the posterior limit
Safe.
of
Yeah.
posterior ethmoid. So that is the ostium of the sphenoid ostium.
Yeah.
So I want to see the ostium before doing posterior ethmoidectomy, because if I keep doing posterior ethmoidectomy, I may accidentally enter into the sphenoid and can damage the structure, particularly when there is anatomical distortion like onody or something. Now, what I am trying to show is,
So this is very important, I think. No, this is again which Satish has brought into this FESS surgery, is the limit. How to be very safe about the posterior ethmoid.
Yeah.
So identify the sphenoid ostium, identify the anterior wall of the sphenoid, and then Okay,
yeah,
Satish,
I
carry
see
on. Yeah.
what I am doing at this
Yeah.
point. See, now going in this, again I am withdrawing my scope and seeing what? See, the maxillary line.
Yes. So the
See in the
level.
sphenoidal recess,
Yes.
staying close to the septum,
Yes.
going
Yes.
not
So,
going above the maxillary line.
so
That's
the
important
horizontal
message.
line. Yes. Yeah.
My message to the juniors is not going above the maxillary line. And see now what I have opened. Can you see?
Yes. Very nicely.
That is the,
Sphenoid ostium.
yeah. Now, that's the superb landmark for me.
So yeah.
I can carry out now my post-ethmoidectomy confidently without any issue. The only thing I need to be careful is not to go behind the level of the sphenoid ostium. What's my point?
Yes. Absolutely.
So now I have a great landmark. I am tension free.
Yeah.
I can remove my post-ethmoids like anything, like a garbage.
Yes.
The only thing is to preserve the mucosa.
So this
Just
is the
staying anterior
sphenoid
to the sphenoid
ostium. This is the wall. Now anything that is anterior to the wall of the sphenoid of the posterior ethmoid is very safe. So that
Yes.
is his posterior limit. So anything up in anterior, the optic cannot be there. So you can very easily.
Even in the
Yeah.
most difficult situation like onodi or anything,
Yeah.
they are always going to behind the level of the sphenoid
Correct.
ostium.
So now in that plane he will go to the lamina.
Yeah.
He will his brush
Now I will
strokes,
remove everything up to
yes,
the
from
lamina.
medial to lateral. Yeah.
So now,
So-
why important thing is again the maxillary line.
Correct.
Why I told you not to go above this? Like you went, if you try to go above here, it
Yeah.
will be in the skull base. This sphenoid ostium is not at the level of the floor of the sphenoid sinus, little at a higher level.
It's always at a high.
If
yeah.
I don't follow the maxillary line and try to look for the sphenoid sinus here, I will be in the cranial cavity.
Yes.
That's my point.
Perfect.
Again,
Yeah.
this what I am showing is the safest way for the junior.
So you
clinician.
identify the sphenoid ostium, widen the sphenoid ostium to its maximum limits, more so inferiorly, correct?
First medially.
Medially and inferiorly,
The
yeah.
safest way
Flush
to
it to the
open
septum.
the sphenoid
yeah.
is just flush with the septum. Can
Flush
you
with
see?
the septum, yes. The
And
medial,
then
yeah.
medially, not not
And
inferiorly,
then-
not superiorly.
yeah.
Now, once I know my posterior limit, I can take away the posterior ethmoidal cell.
This is now
easily.
garbage, yeah.
Now I know as long as I stay anterior to the
Anterior wall of the
sphenoid sinus,
sphenoid, yeah.
I can never damage anything.
Perfect.
See now, under vision, see
And
the
this
lamina
is
papyracea.
width before depth. He's able
Yeah.
to take away a lot of the width, expose really well, and he's not working through a tunnel. All these cells have to go away. And then he is going to, yeah.
I don't want this patient to be reoperated again and again. I leave some of the cells behind. The same story of chronic sinusitis with cellular blockage, mucin, polyps, come back.
Yeah.
Just flushing it. See, the only important thing is preserve the mucosa like a wallpaper.
Yeah.
I don't want to remove even a smallest bit of mucosa.
Yeah. See the trick now what he's doing. The debrider is also cracking that cell. So it becomes mobile and then it becomes easy for him. Unknowingly in a microsecond he's doing several things with the blade of his debrider.
Yeah, you can rotate it.
He's
you
also
can
using
use
it like
as
a probe. He
Yeah.
cracks it. See that? He's cracked it. Posterior part. Yeah. And that's why his. I
Yeah,
mean,
see.
beside yes,
Now
beautiful.
that is your skull base.
Skull base. Yes.
See, that
very
is your
clearly seen.
anti-ethmoidal artery. The
Yes.
skull base. The
Posterior
skull base.
ethmoidal somewhere there. Yeah.
See, what I am trying to ensure, limiting myself
Yeah.
anterior to the sphenoid sinus ostium.
So yeah. So totally,
As long
totally
as
safe.
I
Yeah.
am anterior to the sphenoid sinus, I am 1000% safe.
Yeah.
In any given situation, the optic and carotid cannot come anterior to the sphenoid sinus ostium. Okay?
Yeah.
See, here I am using it as a sucker.
Yes. He has stopped the debriding mode. And he's
Sometimes I
only
use
using
it as
suck.
see this like
Now
a
the
probe.
probe. Now he's cracking it.
So
Yeah.
debrider is a versatile tool. See, all the time during surgery, the single most tool for me to work is the micro debrider. And for the micro debrider to work optimum, the only thing required is a good suction backup. It can ruin your blade, ruin your motor if the suction backup is not good. And see the Arvind. See, this is not what he has arranged for the workshop. This is his primary thing. When he bought the micro debrider, I remember, I told him, and first thing he bought is a strong suction. That's what his commitment is. Amazing suction backup we have today. Now see, I am doing like a junior most colleague, taking care of all the safety precautions.
Yes.
You know, I am
Very-
in the sphenoid sinus here.
Beautifully seen. Yeah.
Yeah, give me a Merocell, small Merocell here for this mucosal loose. See, it is the visualization that makes the difference.
Yes. And it's a function of the besides of course the great surgeon that you are, also the equipment. This is a Karl
Equipment
Stoss
as a-
spice
yes.
system that he's using. In both the theaters we have the spice. Arvind of course owns the HD Karl Stoss, but we
Karl
requested for the
Stoss
Yeah.
Spice is the #1 camera and the Matronic
debrider.
micro-debrider.
Yeah,
These
that
two
combination
things
is
are
yeah,
indispensable for me.
and both companies are giving us the instrument support. Sino-nasal corridor. It's this only. Yeah.
Now see Ashish,
Post. Okay. He's going to talk.
see
Yeah.
that is the post-ethmoidal cavity now.
Yeah.
Can you see?
Yeah. Now this area that he's doing, lot of us tend to leave some cells here.
Yeah.
This
that
is
the
also very
commonest
important,
kind-
and how we
commonest-
learned it was we would finish a FESS and then ask Satish to take over and see what we had left behind. And very honestly, अरे इतने सेल पड़े उधर तो दिखते ही नहीं थे, until he would remove them.
Now Ashish,
Yeah.
see the importance of this thing.
Yeah.
Sphenoid sinus.
Yeah.
Where I am limiting myself to the level of the sphenoid sinus.
Yeah.
Can you see?
Yeah.
Now I will enlarge the
Anterior
of this.
wall
Yeah,
to
it's
the
block
lateral
हो-
limit,
yeah, block हो गया.
and there is no fear of the carotid
Yeah.
because the carotid is way posterior.
See,
not-
I tell you,
yeah.
never ever be fearful about the onodi if you stay anterior to the ostium.
Yes.
Just shatter your fear 100% if you stay anterior to the ostium. Simply you can't damage anything. Even if there is onodi or anything, it's going to be behind the level of the ostium.
Yeah.
So this is the
No.
landmark I wanted. I
So-
told you, post-ethmoidectomy is the only step
Yeah.
which can kill the patient. And this is, see, the intelligent guy, the Mosher, if you heard of.
Yes.
Ashish,
Yeah.
the simplest way to kill a patient
Yeah.
is to do a ethmoidectomy.
Yeah.
He knew this in this beginning of this century, this importance of the post-ethmoidal surgery.
Satish,
Yeah.
you can also show the audience the posterior ethmoid artery.
Yeah. If it is visible, I will.
Yeah.
See. I will, definitely. Again, see, that depends upon the thickness of the post-ethmoid, like anterethmoidal roof. The post-ethmoidal skull base is relatively thicker than the anterethmoidal skull base. So generally, this artery passes through the thickness of the bone and generally we don't see.
Yeah.
Sometimes if the post-ethmoidal skull base is not very thick, then you can of course see the artery running underneath.
Yeah.
Okay?
So surgical tips here now for this widening.
Yeah,
This
simple.
mucosa that is coming, okay
Yeah,
to debride or
No,
No.
never. See now, the surgical tip is stay at the ostium level.
yes.
No instrumentation within
Inside.
the sphenoid
Yeah.
at all. This is an inflammatory disease and benign disease. You can't afford to give such complication by doing anything blindly into the sphenoid. I told you that's the area which contains tigers all around.
No, not blindly. Now that we are seeing that.
Yes, I do that.
Yeah.
Yeah, in my practice, many times I use micro debrider here and there in the sphenoid, but absolutely under vision.
Under vision. Yes. Okay.
You need to know what exactly you are doing. Otherwise, can lead to a disaster. Now, see this?
Hmm.
Now my widening of the sphenoid. This widening I need for my irrigation to reach. Now, as Deepak was asked,
Posterior ethmoidal.
post-ethmoidal. See now, again, the best way, the reliable landmark, most reliable for the post-ethmoid is not the anterethmoidal artery. You can calculate. The anterethmoid 12 millimeter behind is the 12 millimeter behind is the post-ethmoid. It cannot work like that. Sometimes the anterethmoidal artery is pushed behind, and sometimes there are middle ethmoidal artery. I have observed many a time. So, what the best way is, if you identify the optic nerve, the post-ethmoidal artery is 5 to 6 millimeters anterior to the optic nerve. That's the most reliable
If you
landmark.
identify the optic nerve.
That is more easily identifiable.
Yeah. So the
The
posterior ethmoidal
post-ethmoidal
artery is
5 to 6 millimeter anterior. To
anterior to the optic
that.
nerve.
That's the optic nerve here. See that prominence, whitish,
Yeah.
and my post-ethmoidal artery should be somewhere here. Can you see this?
Yeah.
Can you see this structure?
We can see the structure. Yeah.
Yeah, this to me looks like post-ethmoidal artery. But this
Okay.
has a theoretical importance, nothing to do with that.
Yeah.
You need to preserve these vessels.
Okay. Satish, a quick question. Why is your debrider not getting blocked? When we are doing it, it looks like it just what is it that you're doing?
I told you in the beginning, it is
Yeah.
how you use it. Don't press it against the structure.
Okay.
If I am working using my debrider, like for example here,
Yeah.
if I press on the structure, it will clog the cutting edges of the debrider and whatever comes in can block. You
Okay.
have to keep a debrider a millimeter distance away from the area where you want to work.
Okay.
So it cuts and sucks. That's the principle of micro debrider.
Yeah. Fantastic. Super job. Absolutely brilliant.
So the advantage of this cavity
And managed in 40 minutes. Brilliant.
actually,
So-
time is yours. I mean, whatever you instruct.
Yeah. No, no,
I
but
could
absolutely
have finished in
super.
10 minutes as well, but with no demonstration. So I have a reserve of 30 minutes so that
No.
still I can talk
He
on the
will
other
not,
side.
yeah.
Otherwise, I was keeping a reserve of 10 minutes only, so that I could finish off easily. And we can always carry on the discussion.
No,
all
we
the
can
time.
go on. Yeah. So now the maxillary is going to be not
Now,
dealt with anymore.
this is the type of picture I want in my sinus surgery. The
Yeah.
same picture you'll see in the post-op after 6 weeks, 12 weeks, 1 year, 5 years, 10 years, or follow-ups. We have thousands of such follow-ups showing this picture. You put your 0 degree, you should be able to see everything. See, the maxillary is sphenoid, the anterior ethmoidal roof, even up to the frontal with a 0 degree ostium. Can you see?
Beautiful.
And your
Absolutely
lamina
beautiful.
laterally, middle turbinate laterally, very well stabilized. And this is the access. The reason for this surgery to me now more and more is to give access to the topical steroid.
Fantastic.
This is an immune complex disease which requires steroid. I can't give oral steroid for long. So my strategy is to make the patient use the topical steroid. So that penetration cannot happen unless you give this kind of okay?
Yeah. Oh, fantastic.
So now we'll move on to the other side.
Other side. If this is the first case of the Shikhar, I don't know what the next cases are going to be like. Brilliant. Super.
So the all credit goes to
Sir.
the champion Ashish, the Amol, Arvind, Vivek.
Yeah. Only because we are behind you, you can do all this good work.
No, Ashish. This kind
No,
of
just
setup, arrangement,
Fantastic.
the
No,
equipment.
Arvind and Amol,
Amazing.
master.
I told you in the beginning, this is my dream team.
No, even Janki was so praising his setup yesterday, and the way he has lined up and
It is one of the best ENT setups, was. I tell you honestly, not praising him on his face. But this is actually what an ENT setup requires is the good instruments, the proper setup of the instruments. Now going to the other side, now I have to be a little quicker, not very fast. I have time. So Ashish,
yeah,
just do me a favor.
yeah.
Remind me
10 minutes before
Yeah.
I shall. Yeah.
Okay?
Okay.
I will assume unless you don't remind that I have
Yes.
10 minutes.
Yes.
So other side, this is no other structure is visible. These are polyps. I am taking away these polyps.
So no infiltration, no nothing. Okay, he
Nothing,
just started.
Yeah.
Of course, he did his topical a little bit, but
Little bit topical. Ashish, infiltration is a past now.
yeah.
I can't afford to take a possibility
In
of.
fact, it will increase the heart rate.
Yeah, definitely, boss. If it goes in the system, even the mortalities have been reported now in the literature. See all this
So the
polyp, where
middle
it is
turbinate
coming
is
from?
actually, yes, it's coming from the roof. It's actually lateralized the middle turbinate.
Yeah, this is funny. See where it is coming from.
Yeah.
The packing
You have to be
solution
careful in
used.
this.
Somebody in the audience.
They said no 4-1. 4-1. So saline 1,
See,
adrenaline
Ashish,
4. Yeah.
this situation, the most important thing about this situation is to stay away from doing anything in the olfactory region.
Yes.
You also don't inject.
No. Stopped.
Yeah, definitely.
What's your point?
Ashish,
Yeah.
now in our protocol we have included to
Yeah.
take mucosal histopathology.
Yes. What is it? They look like a stalk out there.
No, I take the biopsy from the most relevant sites in the polyp, and this dictates our post-operative treatment.
Oh, okay.
I tell you,
So not the
whenever we get
surface.
the time to
Yeah.
discuss, in every case we take biopsy to see so many things from the surface, whether there are biofilms, what is the thickness of the basilar membrane, how is the mucosal eosinophilia, which is the most important marker, and that will dictate our post-operative treatment.
Oh, it looks like a stalk and the skull base there.
Yeah.
Oops, CSF. No, sorry.
So it is a polyp. Okay.
I think the surgery is over. Thank you.
Now see what it has given. It has pushed the middle turbinate medially, and see how it has thinned out.
It has totally
and made it
demineralized.
floppy.
Yeah.
See, this is, I told you, to give this kind of access. See, other
Mm.
side. I want this access for the irrigation. And this floppy turbinate, if it doesn't give, I need to do something with this. That's what I told you. It is important in this particular case.
Nasal absorption
See,
of,
now
adrenaline.
another important thing is,
If you use frank adrenaline.
Topical.
besides this, I mentioned in the beginning, over 90% of the situation, we have to do something with the nasal septum or the turbinate for the access.
But the trick
Okay?
is apply, don't press. Yeah, yeah.
We need to do something with the turbinate or the
Paint.
septum. See what I have done?
Yeah.
Out fracturing the inferior turbinate.
Inferior turbinate,
See
yeah.
the access we get. There are many ways to deal with these turbinates, inferior, medial, and in the number of cases ahead, we'll show something different in different cases. What I can do with the middle
Satish, I am
turbinate.
officially asking you an unofficial question,
Yeah.
on record for off record.
Yeah.
After doing a FESS, what is actually the physiological role of this middle turbinate? I mean, it's a surgical landmark, I understand.
Surgical landmark
But
is
now
not-
there are no bloody
No,
cells to be
Ashish,
ventilated.
Ashish, there
Yeah.
is role.
Bolo?
Number one, if you
Yeah.
ask the question,
Yeah,
number one, the upper part of the middle turbinate,
yeah.
see medially, is a part of olfactory epithelium.
Okay.
See here.
Okay,
We-
you
we
keep
should
that.
respect.
Keep that.
We should respect.
Huh.
That. Number two,
Hmm.
as you said, is a landmark.
Yeah.
And number three, the channelization of the aeration is important. See, God has created.
So once there are no air cells, what channelization are we
See,
looking at?
It adds on to the surface area of the mucosa. See,
Surface
what-
area of the mucosa. So
Nasal
for
mucosa.
humidification and
Yeah, see, nasal airway
Hmm.
is the protection of the lower airway. It acts as a gateway.
sure. Yeah.
It acts by humidification, warming, filtering, all these functions.
Yeah.
That's why if the nose is bad, the lower airway can go bad.
Yeah.
So this turbinate has a role we should respect. I don't say it is useless, but it has. If you can preserve, you should. But now, in this situation, I told you, I am not going to preserve it completely. See, I told you I have many ways to handle with the turbinate. The one I showed you on the other side is microfracturing. But this floppy turbinate, and this happens mostly when there is polyposis medial to it. So in the end, I have many ways to handle this. Number one, I can bowdlerize it with the septum at the end of the procedure
Yeah.
by making both the surface of the turbinate and the septum raw. Number two, I can suture it. I can put up a suture over here and keep in place. And number three, I can do an anterior wedge resection. That I am going to demonstrate in this case. That's the simplest way you can handle the turbinate, and it will never fall back laterally. Okay?
Yeah.
Now, see, this is what. Now, we are back with the same work. So, I will go quickly. Oh, instrument over there, no? Yes. Here this is. So, the repetition of what I have done on the other side.
Yeah.
You can keep asking questions.
Satish, an input from Gaurav. I think he's somewhere in the auditorium, and I got
Yes.
the anterior end of the middle turbinate also has the highest density of receptors to assess airflow.
Maybe.
If you take it off, the patient might feel that he's not having airflow. That's why it's better to preserve.
Maybe. That's
Not
good
okay.
information.
Wonderful. Thanks, Gaurav. If you're somewhere around, please come.
That's a good information. I've
Unless
never
he's
heard
watching
before.
from yeah.
So I'm doing the same steps, Ashish. We can
Yeah.
utilize this time for the discussion. Anything important I find, I'll keep commenting.
Yeah.
See now, important here is, you said your job is over. What is there in the maxillary sinus?
Yeah.
See the
Yeah.
purulent discharge.
Yes. So we operated on the wrong side, I think.
No,
No, just joking.
See, this is what the preparation matters.
Yeah.
That credit goes to Arvind.
Yeah.
Skull section. Give me this only. Give me irrigation. Pass. Section लगा.
Infiltration करायचंच नाही. Just paint the walls with adrenaline.
Ashish,
Yeah.
do you find any need of infiltration in
No.
surgery after seeing this kind of field?
Not at all.
And for this benign situation,
So injection
Yeah.
is rejection now. Don't worry.
for this benign situation, I
Yeah.
can't afford a chance of giving a possibility of a cardiovascular insult.
Yeah.
You
Yeah.
remember that case close to Thane, Ashish, after the infiltration?
No,
patient
septum.
had the-
Satish, when you do a septoplasty, you infiltrate xylocaine or
Only saline.
just only saline, just
Yes, for
hydrodissection.
hydrodissection.
There's
Now-
no under local.
So this is for the junior colleagues. What I am doing, everyone can do if you have a good
This
visualization.
this is actually the secret of a good uncinectomy. What he has done is mobilize it to the anterior most limit, and then this the debrider has the intelligence
See,
to
this
do it.
strategy is developed with a simple philosophy.
Yeah.
Like for the uncinate bulla or any cell, you stay away from the critical area, bringing it out, away from the structures behind, so you don't damage anything. That is the simplest philosophy.
Yeah. So go till it debrides
Yes.
to the axilla.
See this?
Yeah.
Under vision, I will go to the axilla. I will never do anything to the axilla which can damage it. I really respect
you
the
can-
axilla
yeah, you
because if
can-
it drags the turbinate laterally and closes, everything is a.
The medial half of the axilla should be worshipped,
Yeah.
not invaded. Yeah.
So, other days ka. If you are doing like axillary flap like Wormel is too good, too experienced. He has been doing for years. So he does it in a.
No, he was in the pre-70A, right? So
Yeah. That's why he
we can-
developed.
yeah.
But he does in a proper way.
That's also because Stamberger was before him, and before the cameras came, so Stamberger was like totally scared of frontal.
The problem with
Because
the
he used to-
Stamberger was he was not using the camera.
Yeah, so
He's
he had to
using
bend
the-
a tall guy trying to look up there was very difficult.
So he developed certain strategy technique according to his convenience.
Yeah, and the fear of the frontal.
Yes.
And our little Buttu Sethi was easy. वो बोलता है मेरे को समझता नहीं इतना गड़बड़ क्या है because with the camera he could see it so well. Right.
See that?
Super.
This is with the 0 degree. Now with the 70. Right.
So now the
Janki is here.
the bulla is intact. Yeah. Yeah, Janki.
Yes.
Yeah.
The bulla is intact.
Yeah. So I hope they have induced the patient for Janki. Yeah. Yeah.
इधर जरा पानी देना. I'll go to the other side and show you the cavity. This is the other side cavity. The other side FESS.
Yeah.
Done with the 70 degree.
Now, we've seen it now. How many times you want us to applaud?
No. Janki has come. He didn't see. He was on the way.
Okay. Janki had to see it. Okay. Sorry. Yeah.
See now.
Hmm.
This turbinate I told you is
Yeah.
going to be floppy,
Very floppy.
and we have many ways to handle it.
Yeah.
So I'll first tell you so it doesn't come my way all the time. Though I can operate keeping this turbinate like this, but coming all the way is a problem. So I have many ways. Like I told you, I can suture it. I can do this Bolgerization. So simplest thing I tell you, I'll just remove only the anterior-inferior part, wedge resection of this to prevent it becoming floppy. Okay?
The anterior inferior
ये
part.
नहीं है, turbinate
Okay.
में scissors,
True
turbinate
cut.
में scissors. This is not scissors.
No, this is a true cut.
क्या दिया तुमने यार? Turbinate में scissors है उसमें देखना. Arvind must be having.
I'll
This is
have
not
it.
the proper
if my-
instrument, yeah.
Yeah.
Give me the divider. Leave it. Leave it. See Ashish,
Yeah.
I am removing this wedge of
Beautiful.
the turbinate.
Beautiful. Yeah.
So I do just with a sharp turbinectomy scissor, which I was not having here.
Yeah.
See, I will keep the anatomy of the turbinate intact for future identification as well.
Yeah. Yeah.
Most of the turbinate. This window I have created. See this?
Yeah.
This will prevent this turbinate falling laterally and blocking the ethmoidal access in the future for our irrigation. Now, can you believe it can block? Hello?
Yeah. He's operating. Yeah. Yeah. Satish.
Can
Yeah.
you believe now? Can it block now?
No.
It is trimmed to the extent without causing any problem at the same time. See this?
Yeah.
It cannot give any problem. Now, I will switch over to the 70 at this point to look for the frontal first, like
So-
we did on the other side.
Satish, one small question.
Yes, boss.
Using a 3.5 mm blade or a 4 mm blade?
Yes, 4 mm, sir. Yes, that's a very important question, sir. Sometimes
Yeah.
in the frontal,
Yeah.
in the narrow recesses, you may have to use a 3 mm blade.
Okay.
That's important, the message. Your question is valid. Now, with
So
the
can-
70
he was
degree,
using a 3.5?
this is the bulla below, Can you see?
Very nice, very nice. Yeah.
See now, what I am trying to show you, how to get into the proper plane. The simplest way. At
Yeah.
this point, again, one can get confused where to go. So mop this thoroughly. You will
Yes.
find the space.
That's
Can
the
you see?
secret. Mop it thoroughly. There's always a cleavage between the middle turbinate and that area there.
Yes.
Yeah.
Can you see the cleavage?
Follow the bulla and
Can you
yes.
see the
yeah.
cleavage?
Yes, beautiful. Yeah.
So now
It's always there.
It's
Yeah.
always there.
Yeah.
So now you can go. Now important thing in this region is keep your instrument directing laterally.
Laterally.
See, I am in the cleavage. I am behind this cell. See, sometimes it is fused with the.
Yes, we can see it. The transparent probe behind. Yeah. Fantastic.
I am going to go behind this cell laterally and fracture it out.
Ooh.
that?
Yes.
See that?
So we
what
are
is
there.
up there?
Yeah, yeah, yeah.
So
The front.
why there is a havoc for the frontal sinus? If you have a proper landmass in view, now I will debride it. See, my turbinate is my medial limit. Again,
Yeah.
I will see my bulla is below.
Yes,
I haven't done
ve-
anything to the bulla.
Yes, the superior attachment still intact.
Yeah,
Working
everything intact.
anterior to that,
See,
laterally
now
the lamina,
my
medially.
lamina,
Yes.
the lateral limit you can see.
Fantastic.
See my lateral limit like this and see superiorly. Now,
Too good.
once I see my lateral and medial limit, where I have to go?
Boom, boom, boom.
Where I have to go now?
Only anterior.
Anteriorly to define my most important limit, and that is
The beak.
beak. I will never be satisfied with the frontal unless I flush with the beak. If I do that, I may be mistaken sometimes with the cell as a frontal sinus. Now, see now, working anteriorly, this is the simplest way of carrying out the frontal sinus work.
Yeah.
I don't know why people earlier have complicated the frontal sinus with so many concepts. Believe me, if you carry out the proper work, frontal sinus is sometimes easier than the maxillary sinus work. Sometimes
Yes.
maxillary sinus
Actually,
makes your life difficult.
Satish is on record that the most difficult
Yes, one
sinus is the maxillary sinus.
Yes. See now,
He-
can you
yeah.
see?
Fantastic. Super.
Everything because of lies.
Bombay Pune Expressway. Yeah.
I didn't have
Fantastic.
to do anything. I didn't have to do anything.
Yeah.
The simple philosophy is keep the bulla intact. First of all, 70 degree. The
Yeah.
man of the match for this frontal sinus work is
Mm.
70 degree.
Yeah.
No other telescope or other thing can give this much of visualization of the limits throughout. Visualization of what? Not frontal limits.
Yes.
And now see, with this is my bulla below, the lateral limit, the medial limit, and once I see all this, just go on to the beak. See this beak?
Yeah.
I will flush the beak, go behind, and go into the frontal above. Can you see very clearly?
Yes, we can see clearly.
Everything so clear.
Fantastic. Not 1 millimeter of mucosa damage
Never.
in the 3/4 of its circle.
Yeah. So this is about the frontal sinus.
Yeah. Yeah. We are seeing
So,
you.
Yeah. Now the next thing, again I will show the removal of the bulla and the relationship to the other structures.
This is again, I think, with the 70.
Yes.
Looking at the anterethmoidal, it's a great move
See,
that has.
until now you are working there. There is no
Yeah.
anterethmoidal in the picture. If you
Correct.
work anteriorly, forget about the fear of anterethmoidal. Anterethmoidal is much more behind. Now see, this is my bulla. I am going in this hiatus semiluris superioris. Again, this cleavage. You see.
Yes, yes.
Between
Between
the
the
bu-
middle turbinate and the lateral wall of the bulla, medial wall of the bulla. Yeah.
See this
So
cleavage.
the secrets here are find that cleavage,
Yes.
engage your probe, and
See,
go
all this is
as
possible if you have
superiorly
a
as
good
po-
visualization.
Yeah.
That's how the mopping.
Engage,
See
go
this?
as superiorly as possible.
Yeah.
Go on,
See,
whatever
I'm
is
going
crackable,
behind.
crack. Yeah.
Just
and is
opposed
press-
to the posterior wall of the bulla.
Pressing it laterally to the lamina.
Yes. Go up. Just opposed to the posterior wall of the bulla. See, I have fractured a little bit.
Yeah.
I will remove this with the debrider. Give me. The first. I'll remove the upper part to show you exactly the insertion of the, like on the other side, the insertion of the upper part of the bulla. That is most important to
Yeah.
be seen. Once you see that, That's it. See this? I am removing just anterior most portion of the upper part of the bulla. Can you see that?
Yes.
Now what is coming in the way? I can see my artery behind the suction block. See that? See my artery behind, just behind this. Can you see that? See the artery behind.
थोड़ा सा साफ
Man,
करो.
artery, that is the artery. See that? That is the artery.
Yeah.
Can you see or not? Let me change
No,
the
we
face.
could not honestly see it the way
Oh,
we
come
should
on.
see it.
Okay, again.
Huh.
Can you see the artery behind now?
Yes, we can see it. Yes, very nice. Yes.
Clear? Now,
Yeah.
again, I'll make it clear. See,
Yeah.
what simple thing, that is nothing heroic. The same thing what we did on that. This is the upper attachment of the
Bulla.
bulla, and just behind that is the artery.
Yeah.
Can you see?
Yeah, yeah.
It is always like that.
Mm.
It's not that I discovered like this. It is the God has given us anatomy like that. See now, I will remove this upper part of a bulla a little bit more. See like this. Now you see the artery better.
Very nicely seen now.
So
Convincing.
the message is, as long as your bulla remains intact, forget about the anterothomoidal artery.
Yes.
Clear?
Yeah.
Now that just I remove the upper part of the bulla to
Yeah.
show that space. Now
Yeah.
give me the reverse part.
Yeah.
Okay,
Okay, Satish, we are close to 10 minutes.
10 minutes? Okay,
Close to
done.
10 minutes, yeah.
I will switch off immediately, instantly after 10 minutes without even asking me. they यार तो 10 मिनट ऐसे ही निकाल देगा.
Just हाँ नहीं उधर बाजू के ओटी में भी पूछ लो.
Looking for the blade.
Janki's case is put up. I think Arvind has put up the case that Janki is doing. There is a Shikhar group created, and I think you will get details
See Ashish.
updated. I think all people have
Same
registered.
place where I use this reverse blade.
Fantastic, yeah.
See, to flush this anterothomoidal artery, this cell behind,
Yeah,
up to the anterothomoidal artery. Can you see?
yeah. In the next time when Satish is operating, we'll show you the technique of how to engage this blade. Not very easy.
Yeah,
There is
this
a certain.
is important.
Yeah,
I'll show you
this
the
is-
external
yeah,
camera.
Yeah, but don't show it now because you finished the
Don't
other
say
things.
it's not easy, it's not difficult. I would say
Yeah,
0
yeah.
degree. 0 degree. Now,
वो नेक्स्ट केस में बता यार.
sit there यार. संदीप तो तेरे को बहुत बोलना पड़ता है. It's not using your brain. बोलना पड़ता है ना, सीधा हो जा. What are you doing? If I need to ask to change the
So Dr.
instrument.
Naidu is operating him. He is, I think, a first year MS ENT,
पूरा
but extremely dedicated and already very skilled. I'm sure he's
very
giving
committed.
his professors a complex in this medical college he is in.
Now see
But he
Ashish.
follows Satish everywhere. Yeah,
Now,
Yeah.
now I'll go with a straight blade.
yeah.
This is the lower part of the bulla.
Bulla. Yeah. Tuck, 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 tuck.
I'm used to this 10 minutes philosophy Ashish in
Yeah.
Jaipur.
Yes. Please
I
show
love
it.
this.
Yeah.
See now this is your upper limit of the maxilla. I'll go in the postithmoid.
Yeah.
Okay. What I need to look for is, see that is the superior turbinate.
Yes, it has come in.
This
Yes.
is-
Gaya was there.
Go medial to it. Remove
Gaya,
lower
Gaya,
one
Gaya,
third.
Gaya,
If
Gaya.
my suction doesn't stop, I'll finish in 3 minutes.
Please do so. Yes, we see the sphenoid. We see the sphenoid opening.
No.
No, udhar, yeah, there. I saw it
No,
before
no.
you, man.
No.
There. Of
See.
course, yeah. I'm
There.
smarter than you, Satish.
See this. See, one
Yeah.
can easily get confused with this.
Yes.
Go medial to the
Yeah.
superior turbinate. That's our landmark.
Yeah.
And see what I was looking for next for the upper border of the maxillary.
Yes. Acha, that's why you were not saying yes.
Yeah.
Okay.
Now I will quickly
Jadu pocha.
see. But only important thing is preserve the.
Mucosa on the walls.
See, after trimming this little bit of the superior turbinate, this has never bothered us throughout the surgery. Can you notice that?
Yes, yes.
So the handling
the
the,
middle-
turbinate
middle
is
turbinate,
an
yeah.
integral part of sinus surgery.
Yes.
I tell almost over 90% of the situation I need to do something
Brilliant,
with the
Satish.
turbinate. Yeah.
Hmm.
Now,
खतरनाक.
ये
इधर
the post
इधर
model
ओनोडी है
में-
क्या ओनोडी?
होने
We
दो
seeing
ना,
the
क्या फर्क
optic.
पड़ता है?
हाँ, फर्क नहीं
I never
पड़ता है.
bothered.
But are we seeing the
yes,
optic there?
this is anodi.
Yeah.
Now see why we opted for this technique
Yeah.
of going medially and looking for the frontal.
Yeah.
This is sphenoid.
Hmm.
I should not cross my limit. See, my limit is here. and see where the onodi is.
Super.
If I keep doing post-ethmoidectomy like this
Yeah.
and don't
then-
realize I'm sphenoid or in onodi, I can easily hit this.
Yes.
That's how this onodi has become so popular.
Yeah. And totally taken care of with this technique
yeah,
of his.
Immediately, forget about onodi or
Yeah.
anything. You
Yeah.
can never damage what. This is the simplest philosophy,
Yeah.
and this is what we are giving our students in the hands-on surgical courses to do them follow this.
So don't advertise too much. You already
No,
have
no.
a bloody
No
2-year
place,
wait list
no
or
place,
more.
no.
Yeah.
No advertisement.
अरे
This
फिर
is-
वही अपने को ही
this
गाली
is
मिलता
to-
है. हाँ.
No, this is to encourage the juniors.
Yeah. So there
that
is a
they
hands-on
can,
training
They can do it.
where they can come and operate under his guidance in Jaipur. But there's so much demand there that it is getting difficult. And
Yeah, I am
I
done.
mean,
boss.
no, I know, but I know also. Wow, nice.
See, sometimes if you widen too much inferiorly,
Yeah.
what can happen? You
Septal
can see
branch. Yeah.
septal branch. See, that is because of the more inferior widening.
Okay.
Sometimes it is very close to the ostium, sometimes far off. So you do not need to bother about
So this
it.
used to create a panic in us before. This is क्या है? Bleeding है ना तो रुक जाएगा.
Even if I don't coagulate, believe me,
Yeah.
it will stop.
It will
But
stop.
the simplest way is touch. आगे मत सारे इतना मोटा सिरा तेरा.
So on the Shikhar group, I'm sure all the delegates here, Arvind has posted the
What?
CT scans of Janki's next case. As you
Yeah.
go, this is
I see.
only to help you keep it with you. Yeah.
Timer on,
Sorry?
man. Timer on.
No, we are on, boss. Azun 7 more minutes.
Oh,
Yeah.
7 more minutes. So then
Yes.
what do I do? Okay, we'll discuss something.
DCR
I will
karna.
utilize the 7 minutes. Some important discussion. Some philosophy about why I am doing.
You
minus
can
13.
loan them to Janki if he's ready, and you can take it back.
Guaranteed loan.
Guaranteed loan. Yeah. If Janki is ready to go on air,
No, I
but you
think
can show something. Yeah.
So, see now.
इसका थोड़ा maxillary बड़ा करना चाहिए क्या? Right side.
Not really needed. Ashish,
Huh?
this is very good. This is very good.
This is very good.
Had
No
this
need.
been extensive disease,
हाँ.
I would have done so much to the maxillary. I tell you what would I do otherwise. Now first see the middle turbinate.
Yes. Superb.
See
Yeah.
what I did, just removed a few millimeters.
Few millimeters.
Where's
Oh,
this
and that
section?
also was a flimsy one.
Yeah.
So technically it was not even the turbinate actually. It was
Believe me,
a
Ashish,
yeah.
this strategy works so well.
Yeah.
See, our ethmoid access is so good.
Yeah.
So,
There's Janki. Yeah.
hello.
Yeah, Janki. Hi. We are with you.
Hi. Are we on?
Yes, we are on.
Okay. So that is a wonderful demonstration by Dr. Satish Jain. Following which you're going to see the next case, which is polyposis. So first of all, I thank Dr. Ashish and also his team for calling me here